Welcome you all to this CME, IAS, Indian Athletic Society, which is first in this Northeast region. And we are fortunate to have so many big personalities from Indian Athletic Society to be with us. And I request you to come and have a seat. We'll start the session. We'll do the introduction a bit later. We'll start with the session. And I request Dr. Consultant Dynamic Hospital, and Dr. Chandan, Consultant IAS in the hospital, going to take the chair as chairperson to run the first session. I will all of you to have your seat, please.
Good morning, CMD sir, our superintendent sir, respected guests, and friends and delegates. I have the privilege to chair the first session of Indian Arthroscopic Society, and we are going to have a live demonstration after some time. Right now, we are going to start the theoretical part. The first talk will be by Dr. Sagar Kakatkar. He is from Nashik, and he is an international faculty for many of the arthroscopic as well as joint replacement conferences. He has done extensive work on shoulder. I would like to request Dr. Sagar to start his first talk, that is the graft choice, when and why.
Very good morning, everybody. At the outset, I would like to thank Dr. Guwahati and his team for having us here. And I would also like to welcome you all to this IAS-1. This is the fifth IAS-1 program we are conducting. And I am the first speaker, the evening batsman, to discuss here one of the most commonly discussed topics. That is, how do we decide on the graft choices? So, why is the confusion? Why are we discussing which graft to be selected? Because even after so many years of research and surgeries, the overall failure rates for ACL reconstructions is around 30%, not acceptable. The return to sports for most of the patients still tends to be slightly delayed by at least 18 months. And the main reason which has been given is we are unable to create or recreate the normal anatomy of the ACL, in spite of coming up with different varieties of implants and techniques. So, which are the factors which affect the outcome of which result in failures of ACL reconstruction? The first and foremost is graft selection, which we will be discussing, and the other factors are like positioning, graft fixation angles, the initial tensioning of the grafts, the status of native remnant. Now we have started with remnant preserving ACLs, and if the patient has any concomitant injuries such as meniscal tears and collateral injuries, those are the factors which will end up affecting your ACL outcome. So which are the graft selection criteria? One of the main thing is demography and patient functional requirements. The rate of graft failure, return to pre-injury levels, donor site mobility, risk of future osteoarthritis, the cost effectiveness, and associated complications with the graft harvest. So these are the criteria which we have to take into consideration when we move ahead for any of the graft selection. The first and foremost, these are the factors, most of these factors are the ones which we cannot control. That is the demographics. But in proven that in females or the patients with valgus alignment of the knees will increase Q angles, that is at least more than 5.8 degrees, which has been proven, that is in females. There's a higher risk that the grafts will end up failing, especially the soft tissue grafts. Those with increased posterior tibial load have higher risk of graft failures. There is definite hormonal influence. If the patients, especially the females, who are having a higher quadriceps to hamstring mass ratio and hamstring to quadriceps recruitment ratio, these are the ones which have a biomechanical to have a higher failures. So you have to consider it when you choose the grafts for these patients. And certain level factors such as smaller independent notches and hyperlaxity of individuals. These are the factors which will influence your graft choices. So will the functional demands. So a kind of sports injury a patient is involved, or the kind of sport the patient wants to continue playing, does decide the kind of graft you are going to choose, such as people as sportsmen who are injured and who are involved in legal activities or those who are involved in hyperflexion activities will not be benefited with BTB and physiological older population where there are already chances of osteoarthritis should be avoided in grafts such as BTB. So what all options do we have? We have autografts, mainly the bone-patellar-tendon graft, hamstrings, certain kinds of tendon graft. I have deliberately not included in this larynx graft here, as most of these will discourage the use of corpus larynx as the primary graft. We have other grafts and synthetic grafts also. The gold standard which has been proven over a period of time is the bone-patellar-tendon graft. So why it is important to know BTB, if you check the tensile strength of this graft, it is 2,900 newtons. If we see our native ACL tensile strength is around 2,100 newtons. So we ensure all these graphs have a decent tensile strength. So that is not the issue. The real advantage of BTB graph is it has many projections on both sides, so it's so the graft intervention rate is higher, it heals faster. The graft diameter in BTB graft is predictable. So if you want a 9 mm, if you want a 10 mm, you can choose because you are going to select the BTB category and the graft category. So the value is better to have in patients who have hyperlax because it has got a low failure in these patients. Does it come with no disadvantages? Yes, it definitely has. It does cost patients something that is a donor site mobility is low. Patients will present with anterior repair in the harvesting technique is improper. You can end up with particular fractures. It is not possible to harvest these skeletally immature patients. And studies have reported increased incidence of osteoarthritis with the BTB graft. Is almost 39%, which is quite significant. This is the most followed graft, which I would say that is a hamstring autograft. This can be ordered with gracilis. The semi-diagnosis has been used regularly. It has got the Quadriceps graft has got tensile strength of 4,000, almost 4,000 Newton, which is quite higher than the BTB. It can be harvested in skeletally mature as well as immature individuals. It has got graft side mobility. It also has got some disadvantages. If a patient is undergoing deflection activities, it will not be graft to be used. It leads to hamstring weakness in a longer period of time. The higher rupture rates have got delayed healing time compared to because it's a tendon. If you use suspension fixation, you can land up with a beautiful enlargement because of windshield lateral effect. And like I already discussed, if you have deep happen as individual, and if you only use the ECM without the extraordinary pieces, there are chances that the grafts will fail. The quadriceps tendon grafts are the CKD, a center quadriceps tendon graft or a level graft with a good tensile strength, can be used in skeletal mature and immature. If you're using immature, do not harvest the bone neck. But it's a bit large. If the ECM size is larger than 16 millimeter, and it does come up with a lesser bone mobility as compared to the BTB. It can lead to quadriceps weakness, especially harvesting a full thickness graft. There's fluid extravasation if you are not harvesting it properly. But the fractures have been broken if you have level and sometimes you can have a post-operative hematoma. Allografts, as I already discussed, have not been used that commonly because of the cost issues. There are higher failure rates. There are deep condition details on these grafts. And as we know, there is a higher chance of infection with the use of allografts. Can be used in multi-mix and revision scenarios also. Simple grafts such as LAS have been used and proven all over time that they are associated with higher failure rates and lower incoagulation rates. We have developed simple elements such as internal bracing, which has shown recent results, but long-term results are still awaited. So, what is the best graft choice if you ask me? It should be the one the surgeon is familiar with. So there are lesser chances of developing complications, and it should be individualized according to patient's need and patient's demography. That's all from my side. I would like to invite you all for a wonderful course that is pretty course coming up in April last week. Thank you.
Thank you, Dr. Sagar, for the beautiful introduction. So, as you know, we have some grafts for doing such as arthroscopic surgery, autografts, and there are so many autografts as has been described, like a hamstring, quadriceps, or BTB. I request Dr. Rufus Vasant. He is a senior consultant orthopedic surgeon for the Department of Arthroscopy and Sports Medicine in Premier Institute of Chennai. He will be speaking hamstring autograft. Directly, yeah. Next directly. It's not connected. I see too.
No, actually, it is extended. Okay. Now you can go to Google.
That's right. Perfect. Morning. Morning, I'm Dr. Rufus from Royal Hospital, Chennai. So I'll be talking about the hamstring graft harvesting. So we all know that for easy reconstruction, the most common graft is hamstring.
When we say hamstring is basically we're looking at CME and gracilis. So if it's coming to the anatomy, we have to understand that the layer that actually contains the sartorius and the layer 2 is the MCL. These two, we have the CME and the gracilis. So if you actually look at the image, the sartorius is more like a muscle proximally. As it comes towards the insertion part, it becomes like this ancillus. It's called the loose fat that contains the sartorius fascia, CME and the gracilis. So first looking at the skin incision, normally we calculate the velocity, and the skin incision comes around 2 centimeter medial and distal. There are various layers of the skin incision. There are a lot of people who prefer a transverse oblique or transverse incision. I like the vertical incision. Vertical incision, there are some studies which say that the intrapatellar branch of the saphenous nerve has got a higher chance of damage. We have also seen many patients post-op developing some areas of anesthesia. That's because of this branch of the saphenous nerve. So once you open it, what you actually feel, you feel a bump that's actually the gracilis. And once you open the sartorius fascia, what you see is the semitendinosus. So I'm first localizing the semitendinosus. One thing about CME is that it's inferior when compared to the gracilis, and secondly, it usually contains vincula. Most of the studies say that it might contain 1 to maximum vincula, and that is very important because if you don't properly cut the vincula and isolate the graft, there's a high chance of auto amputation. So always feel for the vincula, isolating both the grafts, that is the gracilis. So the first step is always to isolate both the grafts. Make sure CME and gracilis are identified and separated. And then always start with the CME because sometimes CME alone might be enough. This is something which few studies say that once you take it out, you realize the gracilis muscular belly is more rounded and the CME is more fan-shaped. Try to take as much as periosteum as possible. So some surgeons do put at the insertion site to take as a little bit of periosteum and the bone. I normally use a stab knife. And then we use scissors to make sure that we cut the vincula. Always when we use a curved scissors, make sure we point us downwards or upwards away from the graft when we go down and up. During most situations, we'll be using open tendon stripper. Unless some situations where you want to do something with the graft, like an MCL augmentation or something like that, you might actually use a closed stripper. So that's a good hamstring graft. Always measure the hamstring graft and see whether it's adequate before going for the gracilis. Next comes the graft equation. This is more or less similar to any kind of grafts. Hamstring, just make sure all the muscular bellies go out and make it more clear of a tendon so that it's easy for us to measure and then decide the length and diameter of the graft. These are standard techniques where we make sure all the muscular part comes out so that the tendons are more organized, and any fraying of the tendons or any extra tissues, always cut it off and make sure that it is more organized. It also helps us in finding the exact diameter of the graft. Sure, right, this is not playing. Okay. I'm skipping this slide.
So basically, when you're looking at the graph, we have to look at it can be done as a double strand where we just increase the graft length and then take stitches in the distal part of the openings. Or you can make a triple strand, or if you feel that you have length of the graft, but the diameter is less, you can make this 4 strands, 5 strands, 6 strands. So basically, this depends on how you get the graft. In this situation, the hamstring graft was quite big, it was more than 250 centimeter. So when you it became 120, that is more than enough because you probably look at 20 in the femur side, and the regular might come around 30 to 40, and you might have some 30 to 40. So if you can somewhere under less than 20 to 40 over length, it will be adequate for double stranded graft. So coming to the conclusion, the skin position is very important, which is the family you can do position something which a lot of surgeons are not preferred. See the basis, sample fascia, and then see the cemetery also. I see cemetery basis before anything. So this is congestion as possible. Sure, so that we can identify the outline base of the graft. And semi-continuous alone might be enough for a lot of situations, so wait for the gracilis. And as I said, graft preparation is very important. And I know how to maximize the graft. Like you should be very clear, like whether you should do a double strand, triple strand, but what is required. Thank you. Thank you, Dr. Rupesh. Our next speaker is Dr. S.R. Sundararajan. He is from famous Ganga Hospital of Coimbatore. He's a brilliant student. I know him since a long period of time, and he happened to operate my wife also once at Ganga Hospital. So he will be speaking about the bone-patellar-tendon bone graft harvesting. Bone graft harvesting technique. Just you have the hamstring. So this is I'm going to talk about the bone graft. So usually you do it around start with around 70 to 80 degrees of knee flexion. So you mark your patellar tendon, you mark your patella and the tibial tuberosity. Make a 3 to 4 curved centimeter curved incision. Start just below the tip of the patella. Then you retract with either side with the 2 retractor, small retractor. Then you incise the fascia around the patellar tendon. Then you use a scissor to extend your facial extension on both proximally and distally. Then you retract along with your graft, which already have it. So you expose both the medial and lateral side of the border of the patellar tendon. So then you have the complete visualization of the patellar tendon. Then you mark the tendon in the center around 9 to 10 mm of the graft, usually which you do it in the patellar tendon graft. You can mark it so that it is easy for you to take that central 1/3 of the patellar tendon. Then you use 10 or 11 size blade to make the incision in the mark which you made it for 9 mm or 10 mm. Then use the retractor to retract the remaining part of the patellar tendon on either side so that the patellar tendon is visualized. Then you feel the retractor down so that your skin can move forward, move distally. Now make a 2.5 to 3 centimeter incision normally which you require for your tibial side graft. Normally I use this tibial side graft for my tibial fixation. Then you use a saw blade which is around 10 mm on either side. You can go from 45 to 70 degrees of the angle. Cut on either side. Then use only osteotomy because the chance of breaking the bone graft is very high. So always use this kind of saw, which is very, very essential, like a T-shirt, so that you can make that cut on either side. Then you make a distal cut. You can see that it's angled around 45 degrees. Then you do osteotomy, curved osteotomy to gently tap it on either side. Then come down. Gently tap it because already with the saw, so you need to do a hard blows over there. Just gently tap it. Then you can easily take out the tibial side graft. Just laying it out like that. Sometimes there is a possibility that you can break the triangular bone, which is in the proximal part. It doesn't matter when it breaks. You can use these bio screws.
So this is why you take on your tibial side graft. Once you've done the tibial side graft, you can do an extensions around 20 to 20 to 30 degrees. Then we can retract the skin. So you make an extension of your skin incision. You can see how the skin is mobile. So you need to make an extra incision. So you require the same 3 centimeter or 4 centimeter incision. Then patellar side, we take around graft of 1.5 to 2 centimeter because you have to negotiate the graft to the femoral side. So don't take as a long graft as on the tibial side like 2.5 to 3. So here you require only 1.5 to 2 centimeter maximum. So you just extend the incision on the patellar-tendon, which you are seeing here. Then you use the same kind of saw, angled around 45 degrees. Don't go too deep because you need only 8 mm or 9 mm maximum. Because if you go further, because patellar tendons, especially in the smaller females, the chance of breaking the patellar is high. So we have to be very delicate when we are dealing with the patellar tendon in the patellar side. So this is the graft which I'm going to use on the femoral side. So I need only 1.5 centimeter to 2 centimeter maximum. So here we make the cut on the either side, then make the superior proximal cut, like this at the 45 degrees angle. Then also make a deep cut that under so that you don't osteotomize and to deliver the graft. So remove the soft tissues under the patellar tendon. Then you can see that this is the equilibrium. Then use a saw here, keep it around 7 to 8 mm down. Then use this cut here. So this is more safer than using the osteotome. So the tibial side, compared to the tibial side, you make another cut here. Then you can use the curved osteotome. You don't need to tap it also. Just leave it because you made cut all around. So you can just easily deliver with osteotome. So this is why you get tibial side get around 2.5 to 3 and femoral side you get 1.5 to 2. Then make 2 holes on the other side for the fiber wire or a roti bond which can put it for when you for delivering the graft on inside. So you take a needle with your press and other side you can take it. That is all. Always make it 2 holes because 1 hole can break, especially in a cancellous bone, very weak bones. So I always make it 2 holes. Thank you very much. Thank you, Dr. Sundar. Our next speaker is our friend Dr. Rajiv Raman from Kolkata. He is also a member of our NAROSA, Northeast Regional Orthopedic Surgeons Association, and he is instrumental in helping junior colleagues to get fellowship at Calcutta in many ways. So he will speak about quadriceps tendon harvesting in ACL reconstructions.
Thank you, Chairperson, and thank you, Randa, and to the rest of the invitation. And a special thanks to our President, President Secretary Sundarajan, sir, for starting this first IAS 1 CME in the Northeastern region. Thank you so much, sir. So I will talk about quadriceps, superficial quadriceps tendon harvesting graft technique. It's a real life video technique, so I will not go to the theoretical part. The first and most important part is normally we start this technique, we do this technique in position and marking vastus lateralis, vastus medialis, and the superior pole of the patella. So normally we put our incision lateral to the midline because the lateral side and the vastus medialis muscular to the medial side. So incision should be just lateral to the midline. So just superior pole of the patella and lateral to the midline. Vastus lateralis. So once you make 2 centimeter small loop starting from the superior pole of the patella, 2.5 centimeter, and try to make a sharp dissection over the quadriceps peritoneum. This is very important because we don't want any additions in the peritoneum. We should be also harvested the graft and try to dissect the peritoneum proximally. So once you dissect the peritoneum, the best is in the right and left first. You can see here. So this will guide you in the thickness of the quadriceps tendon. And the second is 6 to 7 centimeter lateral to the midline. So by that you can judge the thickness of the graft. And regarding the depth of the graft,
Again, you can use the side angle forceps to measure the depth of the gap also. So you can see just inside because we are trying to do superficial quadriceps, so try to do 6 to 6 millimeter down and just take the right angle at the forcep. You can see the 7 millimeter thick graft with a 6 millimeter depth already. Once you have lifted distally, try to pass your cinching lead there over the quadriceps tendon and try to release it proximally from distally from the proximal pole of the patella. Either you can avert it or sometimes you can release it with a sharp dissection with 11 under blade. You can see releasing it with a sharp dissection with 11 under blade. And you can see the distal part of the quadriceps tendon is in your hand. Now, 4 to 5 deep stitches started from distal to the proximal part with 5 number 80 bond because normally the strength you require to harvest the quadriceps is more higher because it's a very tight tendon and in the hamstring as you go proximally you feel that it's very easy to harvest a hamstring rather than a quadriceps and then you need a significant amount of force to harvest this quadriceps. And what we do, we harvest it with a normal closed tendon stripper which is available there in the ACL set. Try to dissect it proximally 6 to 7 centimeter. You can see with the same incision I'm trying to dissect it proximally and try to keep the deep layer of the quadriceps intact. Here you can see the deep layer of the quadriceps is intact and that is important because that will not cause any weakness in the quadriceps and post-operatively. Now put the closed tendon stripper and see, you can see my assistant is holding the needle in the bit of extension. It's not a reflection, it's around 70 reflection that will make your quadriceps relax. And take the closed tendon stripper inside, and wherever you will see, you will get a thick, long quadriceps graft. So normally you get 20 to 30 centimeter of graft with this closed tendon stripper only. You can see it is a long graft, it's a thick graft, and you can use it to fiber PCL reconstruction or sometimes then you have a longer vertical graft for PCL reconstruction. So once you have harvested this graft, now you prepare this graft, you can see it's around 32 centimeter graft. 32 centimeter graft, which is a very long. You can use it either for PCL reconstruction or sometimes you can use it for PCL reconstruction. Or when you quadriceps split graft for the PLC reconstruction, you can use this graft. Once you harvested the graft, you can see here we have a deep quadriceps tendon and paratendon. So because we have harvested only the superficial layer of the quadriceps, you just need to close this paratendon only. So try to close the paratendon and then give it 2 or 3 stitches over the skin. And by this 2 centimeter incision, you can harvest a good quality of quadriceps tendon graft. And you can see we have a 10 millimeter graft with 11 centimeter of length, and that can be done with a closed tendon stripper. Thank you.
Thank you, Dr. Raman. Now I'd like to invite Dr. Sachin Tapsri from Pune, a very popular and famous name in Pune. He is the pioneer, one of the pioneers in arthroscopy in India. He got the Elizabeth Fellowship in 1998 as Asia Pacific Fellowship from Indian Orthopedic Association. We will be speaking of 2 subjects: how I make a tunnel and ACL, and probably the surgery of ACL reconstructions. Dr. Sachin, please.
Thank you so much, chairpersons, respected CME. Yeah, thank you. So, thank you so much, chairpersons, dear friends, respected seniors, and welcome to this IAS 1. I think as I stand before you as the president of one of the most prestigious organizations of India, it gives me great pleasure to invite all of you to become members of this very nice organization. And as we can see, that one of the most important aspects that we've decided upon during my career as a president of the Indian Arthroscopy Society is to try and ensure that education can reach far and wide to various parts of India and have all of you involved in the same. How to make tunnels of an ACL? And I think a lot of this inspiration comes from my mentor, the late Professor Ferifu, who taught us a lot that is required to know about the ACL, which has shaped how the way we think about it. Most of it is there in this textbook, which we published about a few years ago. And all of those who are interested can definitely have a look at these various techniques of ACL surgery, which would be a stepwise guide for all of you to go ahead and look at your clinical practice. So how do you make my femoral and my tibia tunnel in primary ACL reconstruction? And the basic objective here is to try and place maximum percentage and cover maximum native ACL reattachment sites. You want to reproduce the anatomy, you want to reproduce normal kinematics, and you want to achieve good pre-injury rehabilitation status. So this part of this talk will essentially look at proper tunnels. We've heard Sagar and the previous speakers speak about how to get a proper graft with the proper diameter, and all of these become really critical. So if you look at the ideal ACL reconstruction, you should be respecting the insertion point on the tibia. It should be a flat and obliquely oriented graft, which will then insert deep along the lateral side of the intercondylar notch, and thereby it will control both anterior translation and rotation of the tibia to a certain extent. This graft will then be fixed with the appropriate fixation modality, and that is what we will be listening in the next couple of talks to come. So here we put my ACL reconstruction. The traditional transtibial technique, which we used about 15 years ago, placed the ACL graft in a more posterior location on the tibia and a very high location on the femur. And this was led to problems where you had issues with poor rotational control, leading to failure of the surgery. You could place it at either of these locations, but I think a center to center or a center to AM position is what we prefer today. So the transtibial technique is a bad technique because though it may control your anterior tibial translation, it cannot control rotational stability and hence should not be preferred. So how can you drill a proper femoral tunnel? And I think the technique is that you need to do it independent of the tibial tunnel so that you can achieve the exact location for the same. There are three different ways in which you can do it. You can use an outside inject, or you could use an AME device, and that will help you achieve the same. An outside in device is pretty good, and we currently will use it, especially if we get a very long B2B graft, or especially in revision situations where you want to avoid the previous tunnel and do a new trajectory. The transportal drill is what we practice most often than not. And later on, in maybe a couple of hours from now, Dr. Sundarajan will demonstrate how he performs a transportal drilling technique of the femoral socket. This transportal drilling technique is suitable for all graft types, and there is absolutely very good visualization of the ACL footprint when we do the same. The transtibial technique with the help of an offset AMO is probably not a good technique, and this is probably avoided in today's clinical scenario. So how do you drill a transportal femoral tunnel? We need to respect portals. So we need to make 3 portals. We need to have 2 portals on the medial side and 1 portal on the lateral side. We are going to be using the remnants of the ACL on the femoral side. We are going to guide us to the exact anatomic location, and we're going to be using certain landmarks like osseous ridges, which one can demonstrate. And again, Dr. Sundarajan will demonstrate the various ridges or landmarks that can be seen very effectively. So what is critical here is to make 3 portals, and the accessory medial portal becomes a very useful adjunct to drill the tunnel, whereas your anteromedial portal becomes a very useful viewing portal as well. So on your left is what you see, how you can view the femoral footprint from an anterolateral portal, and on your right is how the view looks when you switch your scope to an anteromedial portal, which makes visualization a lot more clearer. You should not perform a notchplasty, and you should do it only if you are struggling with some form of notch impingement. So footprints are going to guide you to the exact anatomic location. If you cannot see footprints in chronic cases, then you look at ridges and you look at the presence of this so-called lateral intercondylar ridge or the residence ridge, and the ACL footprint is situated deep to the same. How do we place our tunnel? So if this is the ACL footprint, what we have, I think we need to understand that we need to look at it in what is called as a shallow deep position more than anything else. So if you pass a ruler, which is an arthroscopic ruler, that will allow you to actually measure the length of the footprint and then get you exactly the desired area. A lot of commercially available transportal jigs are available, which are available as offset guides. You can hook them on the back wall of your lateral femoral condyle, and then they can be used to drill a tunnel which is at a variable distance of 4 to 8 millimeters from the back wall. But of course, you need a lot of skill. And usually one size does not fit all. So it is better to individualize rather than go with only one standard size. So, yeah. So what about an anatomic tibial tunnel? Now, if you want to know how you do an anatomic tibial tunnel, it's important that we obey certain landmarks. And the landmarks usually are that you should be about a millimeter or two anterior to the posterior border of the anterior horn of the lateral meniscus. So this is the lateral meniscus, the anterior horn of the same, and we want to be about a millimeter or two sort of anterior to the posterior border of the lateral meniscus. And if you look at the middle and the lateral extent, you want to be a bit medial to the midline because you want to start anterior on the tibia and go deep and lateral on the femoral side. What is important again here is that if you see the tibial footprint as what you see from an lateral portal, at times your landmarks cannot be very clear. But the moment you shift your viewing to an anteromedial portal, that makes a lot of difference because with an anteromedial portal, you can view the tibial footprint in face as if you're looking at it completely from an in-face view, and that helps look at a much better way of visualization. So this is how we need to look when we look at it from an anteromedial portal. We're able to visualize all the correct location, and you can see that you've placed your guide wire exactly bang in the center of the footprint, which then allows you to carry on a good surgical treatment plan. So I think a lot of these principles will be covered in the live surgical demo. This was basically to just give you an overview as to how you should be using anatomic landmarks to your advantage and then be able to drill proper tunnels so that you don't get any form of failures. Thank you very much. On this same talk, I'm going to take it one step ahead and I'm going to discuss with you about how to avoid failure of the ACL reconstruction. So one needs to understand that a revision ACL reconstruction is not the same as a primary ACL reconstruction. And there are basically three different factors of the failure mechanism. So usually it is all three who are at fault. It is a failure of technical details, sometimes of very aggressive rehabilitation, and sometimes even the patient factors make it difficult for all of us. So there are three reasons why your ACL may fail. It could be poor surgical technique, it could be trauma, or it could be a biological failure, which is failure of graft incorporation. Trauma could either be as a result of a re-injury, or it could be as a result of aggressive rehabilitation. Biological failure of reconstructed ACL, though uncommon, is noted. It may be present in about 10% of all patients. And what happened? Oh, since when? Since the first line? Oh, I'm so sorry. Now it's okay. Sorry. So as I said that when you're looking at a revision ACL, it's not the same as a primary ACL. And essentially, we need to look at three failure causes. You have failures which are important from the patient, from the surgeon, and from aggressive physical therapy as well. So if you look at the main causes of failure, they're either failure of the surgical technique, or it could be failure as a result of trauma, or a biological failure, which is failure of graft incorporation. Sometimes you get patients who get re-injured and may cause a tear of a perfectly normally functioning ACL graft, or you may have a physical therapist who is over-aggressive. At times, you can get about biological failure in about 5 to 10% of all patients. And really, we still don't know the causes, but it appears to be related to immunological rejection and some form of stress shielding, especially if you're using artificial tapes along with your ACL reconstruction. But most often than not, it is a surgical technique which has failed, and it could be either as a result of a technical error or a biomechanical factor or a failure to treat any form of secondary stabilizers. Tunnel location, graft impingement, graft tensioning, and graft fixation are the common forms of technical errors. If you have poor graft or if you're using synthetic graft, that may also be a reason for failure. And failure to address a concomitant posterolateral column instability or failure to address a ramp lesion or a root lesion of the lateral meniscus can also be important causes of failure. So if you look at all these studies which were carried out before the year 2000, you can see that technical errors were probably the more important causes. And if you look at the studies after 2000, we will also reiterate the same fact that technical errors are still the most common causes of failure of your ACL reconstruction. Remember, failed ACL, if it fails early, it is usually a mechanical cause of failure or could be a septic process. If it happens in the midterm, roughly around the 2 to 3 month mark, it is again because of a technical failure with the failure of tunnel placements and failure to treat the associated structures. And late failures beyond about a year to 2 years are usually as a result of a traumatic episode. So tunnel placement becomes critical, and on a lateral X-ray, if you draw a line along the tibia, the 42 percentile mark is where your tibial tunnel should be. Similarly, on the femoral side, we draw what is called as the Hurtle's grid, which is a line along the Blumenstadt's line and a perpendicular along the anterior and the posterior articular surfaces. And the ideal femoral tunnel should be at the junction of a third to third, both on both limbs of this Hurtle's grid. So why is this important? Because you can have the following abnormal graft placements. You can have a graft on the tibia which is very anterior and which is very anterior on the femur as well. This graft is going to cause early rupture because as you get your knee into extension, there is impingement in the notch which leads to failure. If your graft is too posterior on the tibia and too high on the femur, this is a transtibial type of graft that will again fail because you do not have any rotational control. And you may have a tibial tunnel, which is either too far medial or lateral, which again causes impingement in the notch and leads to a failure as well. So it's very critical to understand that we make our tunnels absolutely correctly, because as we discussed, a vertical graft will have no rotational control. And if you go ahead and dig again in those papers, you will find that a non-anatomic tunnel was most common error, which was very evident on all papers which are before 2000 and after 2000 as well. So 43% of all ACL failures are because of a malpositioned femoral tunnel, and hence when we're looking at ACL femoral tunnel placement, I would encourage all of you to use an arthroscopic mirror, measure your tunnel, and put your tunnel at the exact location. A small step, which takes about 5 to 10 minutes, will save you and your patient an embarrassing situation from a graft failure. So how do you tackle a failed ACL? You want to rule out any form of sepsis. You want to rule out stiffness. You want to then check limb alignment, look at tunnel positioning, look at the existing hardware and corrections, and then make a proper appropriate graft choice with fixation. Alignment is critical both in the coronal plane as well as in the sagittal plane, and malalignment is going to predispose to ACL failure. Recently, we looked at the sagittal plane in more details, and abnormal posterior slope of more than 12 degrees is something that is going to predispose you to early ACL failure. Here is a patient who's had two failed ACL reconstruction. He plays recreational soccer, and both of the surgeries failed to address a high tibial slope, which was in excess of 15 degrees, which was the primary reason why his ACL kept on failing. In these patients, if you combine them with a coronal plane correction, we have to ensure that you decrease the slope by opening up posteriorly more or twice as much as what you need to open anteriorly, and you need to then use the same appropriate technique to ensure that you have a proper correction in the same. So ensure that you take care of slope before you do any further soft tissue corrections. The surgical challenges for the tunnels will be looking at where the tunnels are, what implants have been placed, and what graft choices we need to make. Graft becomes critical because you want to have good bony healing within the sockets. So we usually prefer either a BTB or a quad-tendon graft to our hamstring grafts, which may then be something that you need to consider. The tunnels and the implants can either be good, bad, or ugly. What do I mean by them? Is that we either have some implants or tunnels which are good for us and some are really very ugly. It's always important to read the previous OR notes, because if you get stuck and you cannot remove the previous implant which has been there, that may lead to a disastrous situation. You may end up getting stuck and you don't find your way out. At times, you can leave secure hardware in place if it is not bothering with your revision ACL surgery. So you can have three different types of tunnels that have been made previously. If there's a completely wrong tunnel, like the one that you see here, it's probably the easiest situation. You just ignore it and do a new tunnel. If you have a completely correct tunnel, then you need to measure it. You need to overrun the same tunnel and use a larger diameter graft. But if you have a partially correct tunnel, then you need to adopt certain strategies and maybe do a two-stage procedure with the stage 1 bone grafting. So when you want to tackle a partially correct tunnel, you can either bone graft in stage 1 and do a revision ACL in stage 2, or you can have a completely new tunnel and use a filler screw to fill in that void and then move ahead with the surgical procedure. A third technique is to use an outside-in anal device. So this is a partially correct tunnel that was drilled in a transplantal technique. One of the ways out is to change the trajectory and use an outside-in drilling technique. So by doing so, you avoid the problems of interfering with the old tunnel, and you get a good bone which is viable, wherein you can now place a good graft, which is usually will have some form of bone plug in the same. On the tibia, if you have a tunnel which is too anterior, you can then go ahead and drill your appropriate tunnel, and you can use a larger screw to shift the graft to exactly where it is. A tunnel which is too far posterior, but not more than 10 millimeters, can again be tackled by enlarging the tunnel and using an oversized screw to compensate for the same. But beware of a very posterior tunnel, which is more than a centimeter away. This results in a very large tunnel in the tibia and may lead to secondary graft rupture because of an attrition problem. So reserve the two-stage if you have a two posterior tibial tunnel, or if you have a large amount of tunnel widening, like in this case. And it's always useful in these situations to bone graft both the femoral and the tibial tunnel as a first-stage procedure. And usually we find that electrous grafts, which are harvested with the help of OCT type of a tunnel harvester, become extremely useful in these situations to get good quality bone. So you can use the Oates set, a 10 millimeter Oates set, and we find that these bone plugs are very effective in transferring bone to the tibial area so that it can be incorporated or tapped inside into position. And this is typically how these grafted tunnels will look at a 6-month time after the surgical procedure. We can see that they look completely pristine, both on the tibia and on the femur, and it's just like doing a primary ACL reconstruction without any doubt for the same. Another example with grossly dilated tunnels, which are humongous. So a CAT scan is completely critical to try and find out what it should be and make sure that you use good particulate bone graft to fill in the tunnels. Missed pathology is responsible for about 15% of all ACL failures. Here's this 22-year-old girl who had an ACL reconstruction done very elegantly, but a large posterolateral corner opening was mixed, and this led to failure very early at around 6 months, leading her to go ahead and need a second stage procedure, which was a revision ACL, this time with bone-tendon graft with a concomitant reconstruction of her posterolateral corner. So do not fail to examine the knee properly. If you have failure of any ACL reconstruction, you have to go through the entire process, ensure that you're not missing out on secondary pathology like root tears of the posterior meniscus or a ramp lesion or a high slope. And always keep in mind that you have to modify the rehabilitation after you've done your procedure. You need to go slow and you need to have a good conversation with the patient about the expectations. And if you want to have a good, successful revision ACL, you need again a well-executed rehab plan along with a motivated patient and an experienced surgeon. So thank you so very much for sticking around with me for these two presentations back to back. We tried to cover most of the basic principles of a primary ACL as well as the basic principles of a revision ACL. And a lot of these principles will be dealt with in the live surgical demo, which Dr. Sundarajan will be discussing very shortly. So thank you once again for having me over here in your wonderful city. And I hope to see all of you in person for all of our IASCon events. I think it's a great society to be with. We have a very rich database of online educational material that is available for access 24/7 for all of you. And we have a very energetic team that is very interested in organizing more and more meetings to dissipate learning and knowledge with, Dr. Sundarajan as our very dynamic secretary with me. Thank you very much again.
Thank you, Dr. Sachin. We'll hold up this academic session for 5 to 7 minutes time. May I now request Dr. Ivan Pradi, who is our secretary for this present IAS CME, to formally proceed with the inauguration ceremony.
Once again, I welcome you all. This is the CME of Indian Arthroscopy Society. IAS 1. This is the 5th CME and the first ever in this part of the region, Northeast part. And I'm very happy to see that so many delegates have from different parts of the Northeast, from Manipur, from Jorhat, from Dibrugarh, from Guwahati, from Telugu. All of them have come. And we have amongst us the eminent personalities from Indian Arthroscopy Society. We have with us our Chairman and Managing Director, Downtown Hospital, Dr. Anand sir, Medical Superintendent, Dr. Udan Bhullar sir. I now request our Medical Superintendent, Dr. Udan Bhullar sir, just briefly address the gathering.
Sorry. Little slippery. Anyway. President Dr. Sachin Tapasvi of Indian Arthroscopy Society, Secretary Dr. S.R. Sundarajan, Organizing Secretary, CME Downtown Hospital, Dr. N. Dr. Sir, delegates and friends. I'm very happy that this very important CME is organized in Downtown Hospital, and on behalf of all the members of Downtown Hospital, I extend you a warm welcome. Those who have come outside, just for the information, Downtown Hospital is pioneer in providing medical services not only to the people of Northeast but also to the surrounding countries. And the basic structure, basic strength of this hospital is not only infrastructure, but education and technical advancement. We encourage our doctors, CMS, and this is one of them. And we have post-graduation in 7 disciplines, and our result is extremely good. With this, I welcome you once again and hope that IAS will consider hosting similar conferences in future also. Thank you.
I now request Secretary Indian Arthroplasty Society, Dr. Sundar Babu, to deliver his speech.
Respected Chairman and Superintendent of Downtown Hospital, my President Dr. Sachin Tapwasi, Army Secretary Iran Bahali, and all the faculty and delegates. I thank for this opportunity to host the IAS 1 CME in Northeast. This is the first CME we are conducting in the Northeast, and I thank Downtown team for hosting this program, and it's well organized. Thank you very much. And at the same time, I want to welcome all the new members. If you are all here to doing arthroscopy or you want to learn arthroscopy, please join Indian Arthroscopy Society. This is just a very simple procedure. Go to the Indian Arthroscopy Society website. It's at www.indianarthroscopysociety.co. Just you have to go and fill your form. Just upload your MS orthopedic certificate. It is done in within a week time. You get a membership. We have a huge materials for the reading and also for the videos. We have around 300-400 teaching videos. We have hundreds of webinars which was conducted in the COVID time. And if you name any international faculty, they are all there in that webinar. So you don't need to go anywhere to learn. Just go to Indian Arthroscopy Society and learn. And I request all of you to participate in the next IAS program, which is going to happen in the Lucknow and all other IAS affiliated programs. Thank you once again.
I now request President Indian Arthroplasty Society, Sachin Shah, to come and address the gathering again. Round for calling. Check. Okay. Yeah, thank you, Ram, for calling me again to come up and address. So, respected CMD sir, Superintendent sir, my dear friends from Northeast, all of you have gathered together in large numbers, and I think it's a very encouraging sight to see that sports is picking up in a big way here. I think probably we should see more of you rather than what we're seeing now, because contact sports like soccer are more popular in your part of the country rather than from where I come. And I think it's really important and very critical that these techniques of doing soft tissue reconstructions on the knee or the shoulder or the elbow, probably you see and you need to serve more people than what we need to do. So I think it becomes really important on all of you people here who are gathered that you do more and more advanced work as you move ahead. And it becomes really important to all of you that you train more of your fellow surgeons to embrace, sports surgery for the knee and for the shoulder, because I think that there's a great area of need for performing, good reconstructions and getting all these young people to be back on track again. Again, heartfelt thanks from the Indian Arthroscopy Society for hosting us here today. I think, as Dr. Sundar did mention, this is our first venture into the eastern and the northeastern part of India, and we're extremely pleased that we could have a grand opening, in the form of Guwahati as the first center. So I look forward to many more initiatives from surgeons from the neuroscience states, and we look forward to a long-lasting association where we can have mutually available exchange fellowships, where we can have a lot of your surgeons who can come and train with any of the centers that we feel like the Indian Arthroscopy Society offers. About 5 positions for inland and about 4 positions for overseas fellowships, and all of those who are interested, I think, should become members and aware of those fellowships, because they're there for your grabs. Just take them and just achieve your dreams and make sure that you have a perfectly fantastic practice setup which allows you to treat all sorts of soft tissue injuries. So thank you once again, and I hope you have a pleasurable next 4 or 5 hours where you have good learning and good exchange of knowledge. And I hope this IS1 meeting can make a small difference in your life. Thank you very much.
I now request
CME sir, Dr. Anandatta sir, MS Dr. Hudan sir, Dr. Sachin, Dr. Sundar sir, and the faculty to come and light the lamp.
Thank you.
Thank you, Ian. So we are going back to academics again. Now from ACL to meniscus. Dr. Sindhu will be presenting about managing bucket endal tear and radial tears.
So just I'll be talking about the technique, how to manage bucket handle tear and the radial tears. It's more of it's a video technique of the managing the bucket handle tear. So it's a 29-year-old male patient presented with the pain and giving away a sensation of the knee for the 3 months duration. He had giving a sensation of playing a badminton. Then it's developed sudden popping sound. Then had a pain and swelling. And as you see this MRI, which has got a double PCL sign, which indicates that this patient has got a bucket handle tear. He also has got an ACL tear with the bucket handle tear, which is a common scenario which you encounter in most of the situation with the ACL. So when you learn ACL, it's very important how to manage the meniscus and meniscus repairing techniques, along with the partial meniscectomy, how to do that. So this is the case which you see here. It's a the bucket handle tear which is locked in the intercondylar notch. So when you do this bucket handle repair, what is important is that how do you position and how to open up your joint space is very, very important. So you keep as well, especially when you are doing on the medial side, you keep it around 15 to 45 degrees of flexion with the valgus force allowing you to open it up. Of course, you can do some pie crusting to get the extension of your opening to do the comfortable repair of your meniscus. When you come to the lateral position, you do the figure of 4 position and do an internal rotation and put a pressure on the knee that will give you the enough exposure to do the meniscus repair. So when you do repairing the bucket handle tear, it is important that you know all the technique of meniscus repair, like inside out, outside in, and all inside. Like inside out, you have the lot of instrumentations now. This is one of the old instrumentation set, but now you have a lot of advanced, just a single handle with the different guides where you can handle your meniscus repair even up to the anterior horn. So you have a curved, straight, for the anterior horn on the body. So you have the different kind of sets are available. And you can use the outside in repair. There is separate sets which you had like a cannula. Even you can use a simple IV cannula can be used for an outside in technique. Basically, this is for anterior horn of your meniscus on the both medial side or lateral side. When you come to the body, always you deal with the inside out technique mostly. For the posterior horn, which you cannot do these 2 techniques, so you go for a all inside technique. So we can minimize that all inside because it's very expensive. So this is how the all inside works, where you comes with the preloaded threads, which comes with a device where you take a vertical or a mattress stitch on the posterior horn of the medial meniscus. As already said, that pie crusting is one of the important technique which you learn, where you go on just above the joint line or below the joint line, just you do the 16-gauge needle. You can see how does it pops out by doing the needling of a superficial MCL, gives you the enough space for you to open up the medial joint space and do little meniscus repair. As you see in this case, that the bucket handle tear is already just merged with the remaining fibers of the ACL. Looks like it is completely fibrosed, but because it's only a 3 months duration. So this meniscus can be repaired. You should save the meniscus. You should not think that it's a meniscus which is 3 months old. It is adhered to the ACL. We cannot do the repair. So in this kind of case, it has to be repaired because considering it's the age group of this patient, this is going to be preservation surgery for that particular patient, and you are going to protect the knee. So if you are not able to reduce it, you can do a pie crusting so that will open up your joint space, then it will reduce the joint. Because it was held in the bucket and lock position for 3 months, this meniscus is not like that in the first case where you reduce it, it goes and sits well. But when you come to the 3 months time, it's always a bit difficult to reduce it. But still, the quality of the meniscus is not very bad. It's very good meniscus. And considering it's almost in the red zone. So the chance of healing is very high for this kind of patients. So reduce the meniscus like this, then you stabilize the meniscus with an inside out technique. So because it is completely moving here and there, so use the inside out technique like this, making a good vertical stitch. So that will help you to hold the position by these threads outside. We can reduce it, then you can go on with the further suturing of this meniscus. So you can see that this is a 2 vertical stitches are made to stabilize the meniscus. then you do a multiple inside out. So the most common instrument which you use or technique you use is inside out when you deal with the bucket handle tear, because now you have a cheaper versions, you have a different needles with the 3,000 or 5,000 or 7,000 with the different companies which is available. So you need to use all inside for all the meniscal repair. So it seems like it's very cost effective. So this kind of preloaded, this is all preloaded inside out meniscus repair threads. So you do 3 or 4 or 5, it depends upon the length of the meniscal tear. Then once you done the once you've done that on the superior side, then you revert that the meniscus. You do the again on same stitches can be used for the on the inferior side, because you do only the superior side, the meniscus get everted. Then you start repairing on the inferior side with the multiple inside out technique to stabilize the body. This is how the threads comes out through the meniscus, and anything which is going beyond the body. If you are going to the body and posterior on junction, then better to use the safety incision. Otherwise, you can use with a small incision like this, you can take out the needle and do the repair. Or you can use the safety incision, which I told, I mean, this is very safe for you, especially in the early part of career, where you have that curved incision on the medial, posterior medial incision, which is the interval which you create between the capsule and the middle head of the gastrocnemius is open, and it is just proximal to the semimembranosus. The same way, the lateral side, you have the safety incision, where you want to protect the peroneal nerve. The medial side, you protect the saphenous nerve. The lateral side, you protect your peroneal nerve, where your biceps femoris is retracted posteriorly by protecting the peroneal nerve, and dissection continue between the gastroc and capsule, so that will help you. And also this kind of curved cannulas will help you to take out the needle, especially when you're on an inside out technique. So when you come to the outside in, so the outside in, you use this, I told the multiple needles, which has got the 2 kind of needles, which like this, where you make a 2 needle incision like, or you can use even IV cannula. You can use the mannitol wire, which is very easy to negotiate. You can use directly threads also, because the water is leaking out. Sometimes using the thread is a bit tough. So this is how you insert your 2 needles here. Then you insert your one is comes with a looped one like this. You can see this is comes with the loop. Then through the loop you can use the mosquitoes from the anterior one to the posterior one. That take it out. Then you withdraw the proximal one, the anterior one. So that take out the mannitol wire. Then you exchange with your fiber wire. Number 0 or number 1 fiber wire is helpful. So this is how it looks at the end of the repair. But you see that the posterior horn is still it's lifted up, because posterior horn needs some stabilization. Then you use the judiciously with your all inside technique. Here, because it's only the posterior horn is left, so I'm using the one on the superior side and one in the inferior side. So you can use as minimum as you can to save the cost of the particular patient. So here, the posterior horns, no other way you cannot use that inside out and outside in. You have to have it all inside. So this is a bit expensive, but unfortunately, there is no other way to repair this kind of meniscus. Then this is the ACL reconstruction. You can see that is the final repair of that particular patient. You can get a biology, especially when you have an isolated bucket handle tear. But when you do an ACL, you are doing already tunneling, so you are creating some biology, you are giving some, but when you have an isolated bucket handle tear, then you can do a microfracture, the intercondylar notch, or you can use a PRP. Still, I don't believe in that, but there are people which uses PRP or a bone marrow aspiration. That was the final repair of that particular case. So when you come to the radial tear, the incidence around 14 to 15%. And the majority of radial tears involves the medial and posterior third of the medial and lateral meniscus. And what is the MRI signs to see the lateral radial tear? You can see the truncated triangle sign, cleft sign like this, or you can see this ghost sign. The prognosis, meniscectomy to reach a stable edge, but when you come to the radial tear, so when you have a post-traumatic, you have a very degenerative radial tear. So both you have to be very, very careful. Any incomplete radial tear, you don't need to do any repair, but it's a complete radial tear. We know that the biomechanical studies have shown that it is like almost like a subtotal meniscectomy. So you try to repair when there is a complete tear. Previously, we used to do only in traumatic cases, but now we started doing even the degenerative cases, just like a root repair. We also do the repair of your degenerative meniscus, but that needs like strong configuration. When you do a radial repair like this, you can do a cross stitches or a side to side stitches. You can suffering. This is a case of 37 years old female with instability, 3 weeks old twisting injury. And this is the MRI, which you can see the sagittal section. You can see the complete radial meniscal tear. This is a common scenario when you see an ACL with a lateral meniscal tear. So this is how you can see what you are seeing in the here is the that is the meniscus. What you are seeing behind is the popliteus tendon. That is not the meniscus, that is the popliteus. You can see this meniscus in the body is completely displaced. So there is no contact between your body and the posterior horn. So when you see this kind of situation, now you can have this kind of small antegrade devices which helps you to do a side-to-side stitches. So here you view from the anteromedial portal. You are working through the anterolateral portal, take the bite on the end posterior horn of the lateral meniscus, the part which was torn. Then you switch your portal. You view from the anterolateral portal, then take a bite from the anteromedial portal to the body of the meniscus. Then you make a rotator cuff tab or instability repair, use the knot pusher, and you can make a side-to-side stitches to approximate that meniscus. Because lateral meniscus has got high potential for healing than the medial meniscus. Anything just you approximate is because it's all post-traumatic situation that heals very well. Then you make another side-to-side stitches to make it more stronger. Or you can use even all inside. If the patient is affordable, you can still use an all inside technique along with the side-to-side stitches that give you more security for the particular graft. And the inner side of the graft, which is avascular, can be trimmed off, and that will give you firm complete repair. This is the same scenario. This 50 years old female patient is a 3 degrees of ARS, is a degenerative radial tear. You get the root tears, or you can have a radial tear which is close to the root. So here the situation is same almost, but in this case we didn't do an osteotomy because it's only a 3 degrees of ARS. But you can see the cartilage is not very bad. Even though the X-ray looks a bit arthritic, but you can see the cartilage looks still very good. But sometimes when you have this kind of radial tear, you can use an all inside technique, which I told you before, where it becomes very difficult to do a root repair of this case because you have a lot of meniscus left out along with the root attachment. So here I use the all inside technique, 1 or 2 all inside technique, so that will secure the radial tear. To conclude, of course, this meniscus tear with all these techniques have a deep learning curve, but a bit expensive, especially when you come to the brachioradial tears or the radial tear, because you had to use a lot of all inside also. But saving the meniscus and knee is important because this kind of tears usually happens in the very young patients. So it is very important to save this meniscus. Thank you very much.
Thank you, Dr. Sandhya. He will proceed to the operation theatre. So before we go to the operation theatre, we'd like to felicitate Dr. Jan.
Since Dr. Sundar sir will be going to live surgery, we would like to felicitate him right now. I would like to call Dr. Chaudhary to felicitate our beloved Dr. Sundar sir.
Yeah. So you can come. No problem.
We'll felicitate him with the bouquet and the moment and Assamese Gamusa and Assam tea. Yes, we can proceed with the academic session now. We'll felicitate the other faculty at the end of this session.
Dr. Sachin Shah will be speaking about ramp lesions, repair options and techniques.
Thank you once again. And again, it gives me great pleasure to invite all of you to come to Pune on the 27th to the 30th of April for knee 360-degree Congress, which is going to cover everything about knee surgery, from soft tissue reconstruction to osteotomy to arthroplasty as well. So if you look at ACL instability, isolated anterior instability does not behave in the same manner as an anterolateral rotatory instability. And the reason being is that the ACL does not work alone. It does have confounding structures, which is essentially on the medial side. You have a posterior the posterior ramp lesion on the medial side, and the posterior root on the lateral side, which are going to influence these form of instability patterns. So ramp lesions essentially are tears on the posteromedial aspect of the medial meniscus. They may either be meniscocapsular or meniscosynovial, and these lesions are responsible for leading to an increased force on the ACL, and they will further propagate and increase the amount of internal rotation of the tibia on the femur and the anterior translation of the tibia on the femur. In these situations, it is completely critical to repair them and have and restore the normal kinematics. How do you see them? Well, I think you need to understand where they are. So you need to look in the back of the knee, in the posteromedial aspect of the knee joint, and you need to palpate them because many a times their hidden lesions which may not be picked up very well on the MR scan. And if you don't probe and look for them, you may miss them on arthroscopy as well. In chronic situations, you can see them in almost about 10% of all your patients. In the acute scenario, you could see them in as high as 40% of all your patients. Why do they occur? As the tibia translates anteriorly, there is an overload which causes the meniscus junction to fail. At the same time, there is a violent contraction of the semimembranosus, which leads to a failure of the posteromedial junction of the medial meniscus. Depending upon the location, you can have them either in the meniscotibial ligament, wherein the whole capsule falls posteriorly, or you can have them in the meniscosynovial junction, where you can have a classic ramp lesion which goes to the body of the meniscus in this particular fashion here. You can look at MR to diagnose them, and when you see edema in the bone marrow on the posteromedial aspect of the tibia, you should draw your suspicion towards these particular lesions. When you look at it through an anterolateral viewing, you pass your arthroscope through this triangle between the medial femoral condyle and the PCL, and you turn the light source around to try and visualize where this tear might be. So an anterolateral viewing maneuver should always be carried out, and any form of suspicion, you should probe that lesion to try and diagnose, the presence of a ramp lesion. If any doubt, you should do what is called a transcondylar viewing, which is pass your scope between the ACL and the PCL, and this will give you a much better visualization of the ramp lesion, which is very critical. If you have access to a 70-degree scope, it makes life even more easier. You can see that I've placed my arthroscope, in the anterolateral viewing portal, and with a 70-degree scope, I'm able to see the ramp lesion even more effectively. If I pass it through the transcondylar portal between the ACL and the PCL, the view becomes even more remarkable with better visualization of the pathology, and the whole ramp can be seen very nicely, as you see in the image on your right, where you can look right around the posteromedial aspect of the tibia and the femur and visualize the ramp lesion, and this is something that you should utilize in your clinical practice. So how do you repair them? You can see that on a volumetric analysis image, you can delineate a ramp lesion. And then the first step is to decide whether you want to do an all posterior approach or whether you want to approach them from the front. If you want to approach them from the back, then you need to create either one or two posteromedial portals. With your scope in the transcondylar portal, you go ahead and you probe the ramp lesion. You then want to freshen it because you want to understand and you want to increase the viability of the raw surfaces. And this you do so with the help of a rope, and then you use some form of suture shuttling device through a low posteromedial portal, pass it through both the capsular side as well as the meniscal side, zone 0, and then it becomes essentially an extension of your shoulder techniques, wherein you pass a suture in, and then that allows you to then go ahead and get a good firm hold. So ramp lesions, I think you need to understand how they occur, and if they've occurred, you need to visualize them properly and then go ahead with the appropriate repair. So here we are shuttling some number 0 suture from a high posteromedial portal through the posterior portal, and then these sutures are then retrieved. You want to ensure that there is no soft tissue suture bridge. And once you retrieve both of these sutures, then it becomes a matter of tying in and sending in a sliding locking knot, which is then useful to reapproximate your ramp repair. These knots should be cinched and they should be tensioned with the appropriate knot tying techniques. And it is always a useful technique to do the maneuver of past pointing, which I'm demonstrating right now, where you pass point beyond the same, and a couple of half hitches with alternating posts are then tied upon to achieve a good, stable, firm repair. You usually need to put in minimum of 2 to at least sometimes about 4 sutures in this particular zone on the back of the knee joint. And that is because lesions which are smaller than 5 millimeters can be left alone, but the larger lesions, which are the ones that we want to treat, are usually anywhere between 15 to 25 millimeters in length. And you need to have one stitch that is placed a minimum of 5 millimeters apart. So the same technique is followed again. You pass it through a low posteromedial portal. You retrieve it through a high posteromedial portal. Again, it becomes a matter of suture shuttling and suture management techniques, which will allow you to achieve a good, stable repair. So you can use cannulas if you feel the need to do so. I personally do not use cannulas very frequently for any intra-articular work inside the knee, because I am just concerned that they crowd my working space significantly, and it becomes a lot more convenient if I can just do away without the form of any cannulas. And this is how your repair should look at the end of your surgical procedure, wherein you've restored the stability on the posteromedial capsule of your, the posteromedial aspect of your meniscus. If you have a predominant meniscosynovial tear, then you can repair it from the front as well. So first you perform a pie crusting, you probe the tear, and then you go ahead and rasp it. You can then use all inside devices, which are predominantly passed on the undersurface of the meniscus. So the device that you use should have a reverse curve pattern, and then you can use a series of such devices to fix the ramp. So to conclude, I think this is a hidden lesion, but is still present in almost about 15 to 40% of all patients. You need to have a high degree of suspicion. Anyone who's got a high pivot shift or the presence of posteromedial bone bruise on MR scan should be the one that you should be aware of. And then you should go ahead, recognize them, repair them, and then move ahead with the same. So again, a warm welcome from the Indian Arthroscopy Society. And thank you so much for being a part of IAS 1 meeting today. Thank you.
Thank you, respected faculties, for the excellent and brilliant academic session. May I now request Dr. Iran to proceed with the felicitation announcements.
So you can stay back here. I'd like to felicitate Dr. Sachin Tapasvi, sir, the President of Indian Arthropedic Society. I request Dr. Partha Chakraborty, Professor and Head of the Medical College, to come over here and felicitate with a Pulam Ganusa. A bouquet, a memento, and some tea again. I'd like to felicitate the other speaker, Dr. Sagar Kakatkar. Dr. Again, I think you have to him. Like to felicitate you with a Fulam Ramusa, bouquet, memento, and assembly. I'd like to felicitate our chairperson, Dr. Utpal Kumar Tamuli and Dr. Chandan Nath Chaudhary. Please come over here. And for coming and sharing the session early in the morning on Sunday, I know. I'll do the honor. Nila, live surgery you can talk. Call. I think we have come to the end of this session. If there is questions, one or two we can take. And after that, we'll go to the live surgery.
Any questions to any of the faculties, please?
We'll finish it with the other faculty after this another session because we're running short of time now. If there's no question, then we'll go to the live surgery. Have you informed?
Check.
You can connect, start the live content.
It's already live there.
But there, I don't think they are able to see. Where it's called?
Sorry? 8 minutes.
You have made it live just now?
What is the live?
हेलो ये लाइव दे दो भाई लैपटॉप का दो दिन
They are not able to see that.
दो शो कर दो लैपटॉप का वो कर दो
What is the history?
अरे लैपटॉप का फीड उसको दे दो भाई वो जूम का फीड उसको दे दो। हाँ, जूम फीड रेडी का दे दो।
350. Start, sir. Focus on that camera.
Which one?
That camera now. The other camera.
ये ना
जो OT टेबल वाला कैमरा है, OT टेबल पे दिखा रहे हैं।
Session, Dr. Rajiv Raman. Yes. Well,
आइडिया है क्या?
आगे
ब्लैंक ब्लैंक
एक
So,
चेंज करना है।
चेंज कर रहे हैं। सर हम चेंज को ये और वीडियो हमने
अरे हेलो हेलो हेलो
हेलो हाँ
we can hear you, but the visual is not here.
वीडियो तो हो रहा है, वीडियो आ रहा है भाई, उसको मिला वो लैपटॉप का कनेक्ट किया है, वो एलईडी का स्विच करके मिला। अच्छा बोल रहा है हेलो
We can hear you, but there is no visual.
लगे लैपटॉप का वीडियो की वीडियो नहीं आ रही। ये आ रहा है ना, ये आता है ना, वो जूम खुला दिया ना, हाँ, उसका आ रहा है चेक करते हैं। अरे चलिए तुम्हें बोल ठीक है बोल। हेलो
Hello, yes.
अभी वो जूम का रन हो रहा है ना, अभी जूम का कनेक्ट किया है ना, हाँ उसका आ रहा है ना वीडियो, चेक कर दो।
Ajit is there. Ajit, can you hear me?
ब्लैक ब्लैक आ रहा है, आया
See the screen, but there is no visual.
अभी देख
यहाँ पे ठीक यार ऐसा है
अरे लैपटॉप का जूम आ रहा है।
But tested it is okay now. It's not coming. They can hear us, I guess. Can you hear us? Iman, keep.
सर अपना स्मार्ट IAS है, वो वीडियो तो बोले कनेक्ट हुआ नहीं है मैं तो पता पड़े तो टेक्निकल की वजह से।
अरे भाई
मैंने ऐसे हमारे कैमरा फोन देखा है ताकि
अरे मेरे दूसरा स्क्रीन भी आ रहा है, देख लो, सर्जरी का स्क्रीन आ रहा है, देख लो।
not streaming, they're not able to see that. Streaming it is.
Huh?
There is some technical glitch. Let them sort it out. Till then, we can have some queries in the first session. Will other faculty will take other questions. Any queries you have?
Or any question, I think we can have a discussion on that. I think there is an issue. I think it's coming there. The issue in the
They are sorting it out.
it will take another 5 minutes, I think. Yeah.
अरे पंकज भाई, you just go to the laptop and you just go to the console. Can you see the surgery going on?
You say.
मिला है सर, ये तारे तारे टेक्निकल टीम वालों का प्रभाव देखते हैं।
You are not getting? Hey, no, don't see the LED wall. See the zoom.
Who is the keeper? Is the Bubicon?
See the laptop. Think how this is going. What you're seeing now?
Yes.
Same. And even the same maybe. Okay, you do one thing. Connect your laptop in the podium. Hello.
It's in network error or what? Actually, keep a hand going. If I restart करके देखोगे?
नहीं, it is streaming.
Streaming, but it's not. They are not able to see them.
नहीं, मेरे को आ रहा है देख लो
Are you recording?
अभी आ रहा है.
You are recording or
You
not?
connect your laptop in the podium where there is HDMI and I'll share the credential. Yes, right now.
Larry, how are you?
Because you have tried to sort out the thing, otherwise suddenly the thing. Go and talk. Go for it. I think you should stop the streaming and restart it again.
No, it is streaming.
With the app.
Hello. हाँ पंकज जी. हाँ. Just join with this credential. You connect your laptop. Here it. Link नहीं है. Login credential. Meeting join.
Hello. Sir, वो तो YouTube पर स्ट्रीम हो ही जाता है. अपने द्वारा. ये पंकज. Connection to actual purpose. Yeah, but
Are you getting? Hello. Pankaj ji, you are getting? You just connect to that to display. तो अभी आ गए हैं ना?
Video is coming. The YouTuber.
Hello.
Yeah. They're ready. They're ready. Yeah.
Yes. Sundar sir, can you hear us? Hello.
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 You have to play the iPad.
Check.
Hello. Sundar sir?
Yeah, I can hear you.
Rajiv here. So,
Rajiv, yeah.
you are
Rajiv.
live, please. There was some technical delay. Now, I think you are live now. So, we are harvesting the graft.
Yeah, we harvested the graph just now. Yeah, we played the playback the record.
Yeah.
Graph harvesting.
Make it a full screen.
The playback.
Yes.
So Rajiv,
Yes, yes.
this 28 years old female is a recreational player, had a fall while playing badminton,
All right.
has a ACL injury. Hello.
Yeah, we can hear you.
So just we harvested the graph.
Mic, thoda volume mic, speaker.
Can you see them?
Yes, we can see.
So it's okay. So what we made is incision, we made an oblique incision. I made it little longer incision for the better view. Okay.
All right.
Raju, can you hear me?
You are audible, please.
Yeah. So this just we are playing back the recorded video of graft harvesting. Okay.
Yes, we can see.
So that is the piston series sheath which is inside, as you see here. And normally, I mean, I don't go from outside in, I go from inside out technique. So what you are seeing, the underlying structure is the superficial, the shining structure.
Yes.
And what you are holding in the artery forces on the tooth portion is the piston area.
Hmm.
You know the other view, to see from the inside? No. What is shown from so what I'm taking to the artery forces is the piston area shield. Okay, so unfortunately, I think take from the other side, which is a better view to show the both CME and grace. I think already Rufus had shown in the video where you see the down one, which is always CME. This is the CME.
Yes.
And it goes downwards, and it's got a 2 to 4 wind fly, which was released after taking out that attachment to the piston area. So here, because considering a size and the graph size is bit smaller, so we wanted to take both CME and grace. Okay.
All right. So you are planning to
Can you see now?
iPhone? Hello.
Rajiv?
You are planning to have a 5 glass. 372 glasses.
That is the CME. You can see that is the CME. We are releasing the wind flow by facing the scissor downwards. Okay.
Yes.
So we should not face it upwards because the chance of getting the graft cut is very high. So we have to make the scissor downwards and make it remove the wind to the wind plane. Because if you don't remove the wind plane, the premature cut of your CME is very, very high.
Mm-hmm.
Unless the grace list doesn't have any wind plane, but CME will have a 2 to 4 wind plane. So you have to start from approximately deep. So you have to take all the wind plane by just using the scissor, you can release it very easily. Then make the 3 or 4 stitches with stitches like this, so that always you have the security of the graft. Sometimes it can retract inside. If you don't have enough security, then you have to trace the graft, it is going to be down. So always use the stitches so that you have a more security. Then I'm using the closed stripper here. It's a 4 mm stripper. Sorry, what is the size of stripper? I think since I don't know, I'm not sure that we removed the CME and we thought that graft size may not be sufficient for this particular patient by doing especially the lengthwise, considering the short female.
All right.
So we took the graceless also to make probably we make 5 strands. So probably we will be getting around. I'm not sure, but we may get at least 8 in the tibial side. Sometimes we get 7 in the femoral side. But considering the size of the patient, I may accept 7 in the femoral side and 8 in the femoral. If we get more on 8, it's good enough.
So what we have done is that that is the graft preparation. Dr. Vedagopal is my fellow. He is going to prepare the graft. So we are planning to do a 5 stands. No? We are planning to do a 5 stands. That means we make CME as a 3 stand and Grace is a 2 stand. Okay.
All right.
So we go inside the joint now. Already made my lateral portal. The lateral portal always little higher portal, just lateral to the your patellar-tendon.
Cameraman, can you show the inside picture? Cameraman, please shift to the inside picture, or you can make it picture in picture.
Yeah, you can show the even graft preparation. Because instead of outside view, you can show even that graft preparation if you want.
And
What is it okay?
yeah, now we can see inside.
Yeah, so we can see the I'm in the suprapatellar pouch. Can you see the video better?
Yes. Now we can see. Yes.
So I'm in the suprapatellar pouch. If you are a beginner, you see my camera, the cable. You see the camera cable in the down, and your right source will be off to see the suprapatellar pouch. That is the trachea of the femur. You can see that the medial and lateral condyle of the femur. Then you rotate the light source 180 degrees to see the undersurface of the patella. Okay, so that is the patella. You do the full diagnostic round. Then you take the scope on the lateral gutter. So that is the lateral gutter. You can see that is your popliteus tendon. If you go down, you see the popliteus muscle too. So sometimes you can get some loose body. Okay. So once you finish the lateral gutter, then slide your scope on the medial gutter. That is the medial gutter. Sometimes you can see the loose body. Sometimes you can see the peripheral meniscal tear. That is the medial meniscus. Then you come to the intracondylar notch. Then you flex the knee to 90 degrees. Then you will be in the intracondylar notch. Do you have a needle? So if you are a beginner, better always use the needle for your medial portal. As Sachin said, you can use the 3-portal technique, or sometimes you can use the 2-portal technique. The 2-portal technique is generally usually it's a formedial. That is, this is the medial part of the patellar-tendon. You take at least 1.5 centimeter medial to the your medial to the patellar-tendon. Okay. The length of the needle is not okay. Okay, it's okay. Can you give me this nice long knife? No problem.
So for ACL, you prefer the central portal.
Sorry?
For ACL, you prefer central portal also.
I prefer the single portal. Okay. So you can see this is how my knife comes there. Okay.
Yes.
Can you see that? So it has to go to the lateral condyle in this direction. So that is the direction for your transportal technique. So always insert the long needle. Make sure that you are in the correct place before you put the portal. So even if you make a wrong portal, nothing wrong in that. You can make an adjustment. You can make one more portal. You can make anywhere. There is no neuroobstructus here. You can make anywhere. Okay. Then you come to the condition. Yeah. So open up the medial compartment. As you see that I'm using the lateral support. I'm having a 30 degrees of flexion and doing the external rotation of the foot. Can you give the flow, please? Shiv, Dr. Shiv is assisting me. You can see that is the flow, that is the meniscus, that is the posterior bone, and that is the root. All looks to be okay for me, and MRI also shows there's no meniscal tear. So the medial meniscus is fine, condyle is fine. Do the figure of 4. And do the figure of 4 and internal rotation. You can see that is the lateral meniscus. Looks very good here. That is the anterior horn. That is the body. That is the posterior horn. That is the hiatus. That is the popliteus tendon. Okay. So here everything looks to be perfect. Can you make 90 degrees? Yeah. So there is no obvious. Obvious meniscal tear. Anyway, I'm trying to look for the for the ramp also. It's very big tight joint. Right here the
Can you tell us about the tips, how to reach the posteromedial compartment to see the ramp tail in intact PCM?
Sorry?
So how to visualize the ramp here, if you can show them?
Can you do the voice is not clear?
Voice is not clear. The question they are asking.
The question what they are asking, you are not able to.
No. What the question they are asking, no, it's not clear. The sound is not coming
The
through.
joint is bit tight.
Yeah.
So I'm not going to open it up. So I will just straight away go ahead. So you can see that is the remnants of the ACL fibers over here. Can you see that? So that is the ACL remnant fiber. Always the tibial side you will have the fibers, tibial fibers, and the femoral side you have a small remnants. And you can see that is the PCL. I'm just clearing that intercondylar notch where your remnants of the ACL is there. You can see this is the PCL. If you're a youngster, you can see the PCL is from the 2 o'clock to 6 o'clock position. I mean, almost the entire half of the intercondylar notch is occupied with the PCL. Then you clear your soft tissue clearance for your intercondylar notch for your femoral entry point. So what I do here, it doesn't take much time. The femoral side, normally you don't get much remnants unless it's a type 1 or type 2 or a type 3 tear. And as Sachin said that you don't need to do a notch plastering for in primary cases like this unless it's a very chronic. And if you have an osteophytes, then you do the notch plastering. Otherwise, you just take out the soft tissues to see that entire notch probably from anterior to the posterior direction to make your correct entry point. And this is how you clear the joint here. As a beginner, I would not recommend to keep all the remnants of the femur because it is not grow. You should not make a mistake of doing a wrong tunnel in the femoral side. So better to clear, see it properly, and put a probe to see the posterior end of your notch. You can see, I'm putting my probe, though that is my posterior end. So we should not make a mistake which we should not come to anteriorly. Sometimes what happens with Sachin talked about your residence ridge and the lateral intercondylar ridge. Okay. So if you are sometimes what happens in the scope, if you are not used to this or you have not done many cases, especially if you are a beginner on the first 1 or 2 cases. This case you can see that once of the clearing probably. You are able to see a lot of bone behind that. So what happens sometimes when you see, you think this is the posterior end. So that is the residence ridge. Normally it happens here. But you see that after that there is so much bone left here. Can you see that? So the residence ridge comes here. That's what you are talking about. And the lateral intercondylar ridge comes here. But it is not present in all the cases. It is around 60% of the patients will have the lateral intercondylar ridge. So why the lateral intercondylar ridge is important? That means that you are not going above that. You know, your entry point is going to be only this level, not going to be high. There are 2 ways of making an entry point, which one is which Sachin showed that you can make in a ruler from anterior to posterior. Then you take the 40% of your intercondylar notch, you calculate, and take the 40% from posterior to anterior, then make a mark, then you can make an entry point. Or you can use the jig, which is the transportal jig, which is available from 4 to 8 mm. We can use that normal transportal jig. So in general, I think you don't make a mistake. Either if the notch becomes bigger and bigger, you can use the bigger transportal guide with the bigger offset, like a 8 mm, 7 mm, 6 mm. When the width of the notch is smaller, then you can bring it to at least 6 mm of the 6 mm offset. Don't go 8 mm because otherwise you will end up on very anterior. Yeah, thank you. So this is the transportal jig which you are able to see here. This part goes and sits in the behind your posterior intercondylar notch. Can you bend the knee to 120 degrees? The knee is around 90 degrees. Now you can see that I'm going almost around 110 or 120. And this is going to be my entry point. Yeah. If you want to have a, yeah, go.
So what is the size of offset? Sundarshan?
This is 6 mm offset. Go.
All right. And what is the diameter of graft?
Diameter of the drill is a 3 point, it's a spade guide wire from the arthritis. It is, I think, 3 point, what is the size of the? 2.4, and the tip is only 3.8.
The tip is not
9 for the butter. Go. Yeah, thank you. If you have doubt, you can always take it out and see again whether you are in the correct position or not. Or if you are confident, what is the size of the?
Sundar sir, there's a question in obese patient.
Sorry?
In obese patient, if you cannot do hyperflexion, so how do you plan for a femoral entry point?
Not able to.
In obese
Can you
patient,
come again, because we are, the voice is not very clear here, but what you are, can you come again?
see, in obese patient,
Obese patient, okay.
how do you decide for a femoral entry point? Because sometimes hyperflexion is not possible because of big
Yes,
thigh.
sir. You can get around probably 90 to 100 only, because the thigh may not allow you to have a entire flexion. So in that cases, you have to be very careful. You can make it in a freehand technique, like how you Sachin showed, you use a ruler, you make it that 40% from the posterior to anterior. Then that could be an ideal entry point.
And then try to.
In the obese patient. Still, my entry point, I feel is slightly posterior, but it doesn't matter. But especially because you are using an adjustable loop, it doesn't matter.
You can.
What is the? So what I predicted is, because even after making the 5 strands, I got 7 in the femoral side and 8 in the tibial side. So that's how you get this kind of patients. But I accept that because I don't want to take another graft for this. Can you give me 7 mm reason? What is the length of the graft? 8. So we have the length of the graft is around 8, and this is the, so this is very important. This belt guide wire comes with the measurement. You can see, so this is around 32 or 34. Yeah, that is the 4, so that means 34. Length of the tunnel is 34. Can you put it on? And I'm going to make a femoral tunnel around 22, because we have the enough length of the graft of around 8. And also when you are, so when you are inserting, so make sure that you don't touch the condyle here. Okay. The most common mistake is that if you make a far medial portal, when you insert your 8 mm reamer, it can damage your condyle gears, and you should not try to ream. So make sure that you see under your vision, then you slowly negotiate to the condyle for the reaming. So I'm going ahead with the reamer.
So your tunnel length is 40? 32.
34 or 35. I'm reading around 22. So here what we are planning to use is the adjustable loop. So it doesn't matter how much length you require. When it depends upon the length of the graft, you can adjust it. So the same thing, sometimes if I'm using only a 17 to 4 strands, then I use only 18 to 19 mm of the tunnel, because if you get only 7 mm of the length. If you get a 7 mm length of the 7 mm of the graft, 7 centimeter of the graft, then I use only 18 or 19 mm, not more than that. Okay, so that is by the femoral tunnel. You can see it from the medial side too. So to see the better visualization, can you see the tunnel?
Yes. The posterior wall is intact, almost you have to.
In fact, because it's an adjustable loop, even if you break it 1 or 2 mm, doesn't matter, you can slightly go deeper and you can solve it, not an issue at all. So once I finish the femoral side, then you come to the tibial side. For the tibial side, there's already the landmarks were told by our Sachin. And also when you are developing the graft, you can see some kind of remnant will be here. You can see that. Unless you come anterior, you will sometimes miss, and if you miss it, you can form some cyclone. Then it can give a restriction of your last few degrees of the extension. A patient can go for a 5 to 10 degrees of FFG. So it is important to remove that, what are the remaining issues in the front. So you can see that. So you have to come anteriorly. This is the anterior of the medial meniscus. That is the remnant of your ACL. This is your anterior of the pro. So as you see here, as he said that this is the anterior of the lateral meniscus, posterior border. This is the anterior border. Your entry should be almost close to the posterior border or just anterior to the posterior border of the anterior horn of the lateral meniscus. It is supposed to be here. Okay. So that means your anterior tooth, 2/3 of your ACL is corresponds to the anterior horn of the lateral meniscus. So you are trying to aim on the just anterior to the posterior border of the anterior horn of the lateral meniscus and slightly on the medial side. Okay. And this is the jig which I am going to use it. You can see there is a mark. So this is not going to come in the tip of that. It is going to come here. So there you go.
So you try to be at the center of the footprint.
Not the center of print. My aim is that the entry point is just close to the posterior border of the anterior horn of the lateral meniscus. You can see the anterior horn of the lateral meniscus.
Right.
Yeah. I'll show you again. Can you give me the floor? Can you give me you can see that is the posterior border of the anterior horn of the lateral meniscus. So your entry point is just anterior to that. Can you see that?
Yes, we can.
Slightly medial. Huh? Can you give me a system of river or a So always you can use the start with serial reaming instead of directly using 8 or 9 mm, because you can still adjust if you're making a 4.5 mm reamer. You have 4.5 or so. You don't have. Not there. I'll give the 4.5.
So Sundar sir, will
So 4.5 first. Yeah, yes.
will you check for improvement after putting the wire?
You mark it for 22. Yeah.
Cameraman, please clear the picture inside view. Cameraman. So normally you have 3 points there. Either you can use the anterior horn of the lateral meniscus as a reference point, or second reference point is medial tibial spine drop point, and the third is the PCL. So I think if any of the 3 reference point is good enough, you are comfortable.
Otherwise, right. Yeah, thank you. So you can see that is the entry point. Okay. So what helps you artery forceps? So if you think that you made an entry slightly in the anterior, then what you can do, you can use this, you can push it posteriorly, you can read it, so it will take extra 2 mm posteriorly. If you think that you have gone too far medial side, then what you can do that you can push this on this side and start reading. The same way you can adjust it all the 4 directions, so that if your entry point is slightly on the wrong side, then you can adjust it by holding like this. Okay.
So after removing it 4 millimeter, you can adjust it to 2 millimeter anterior, posterior, medial and lateral.
As you see here now, we did the same demo. You can see that I am in exactly center of the remnants of the ACL. Okay.
Yes.
So that gives you an idea that whether you didn't go too for medial, too for posterior, too for anterior. And you can see that is the entry point. So before that, we mark the, you can see the, you can show this here. So this one here. You can show this one. So this is the adjustable loop, okay? Can you see that?
Yes, we can see.
So there are 3-4 threads here. You can see the white white one. This is the one which is going to hold the graft. You can see the tape here. So this is the tight rope 2. Okay. So this is the tape which we normally use the fiber wire in the first generation that can resulting in more friction or irritation on the reconstruction the graft. So this tape is better. So this is the white one which is holding the graft. You have the another 2 threads. One is blue, another is the tiger. So this is the holding the button. Okay. So either you can pull only the blue or the tiger, or you can pull all 3 together. And you can also clip for the after once you cross the forecortex, you can make sure that you are clipped well or not by doing the clipping like what you do for a fixed button. You can do the clipping of the both the blue and the tiger. Once you confirm it, then you can pull the white threads to take the graft inside. For the measurement, so you keep the button vertically. Our tunnel size is 35. So you mark it with the 35 mm. So the tip, yes. So you are measuring the tip of the button. Okay. Yeah, you correct. Not 35.
From the tip of the button.
Yeah, from the tip of the button, it is 35. So that means you are, once you see this mark at the end of the tunnel, at the entry of the tunnel, that means your graft has passed out of the tunnel. Already you marked the graft, how much you have to go inside, that is 22. It was marked by Venugopal already. This is the graft length which I wanted in the femoral side. Okay?
All right.
So, plus the region. Come out. Okay. The other can.
Sundar sir, there is one question from audience. When you are using as an internal brace,
Sorry?
internal bracing in ACL reconstruction, when do you plan? Internal bracing.
Internal bracing in. Oh, internal bracing. Okay. No, I don't do the internal bracing. I mean, many people do that. I don't use the internal brace in ACL reconstruction, but I used 1 or 2 cases in the primary repair, not for that regular reconstruction.
Because the graft and the soft tissue graft and your fiber tape has different tensile strength and different elasticity, better avoid using this internal brace in ACL reconstruction.
I mean, I use the internal brace for MCL. Sometimes when there's a bit substance there in acute cases where you don't want to do a reconstruction, I do the for the MCL, not for the ACL. I don't do that. Can you take the you come this side, shift from this side. Yes. Okay, pull, two, three, pull, 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 two. Come on, pull, 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 pull. Come on. Yes, that's it. So, pull all together. You can see that button is going here. So sometimes it can go on stuck with your tunnel because if it is lies horizontally, you can glue as a leading stitch and you can go along with it. Now you can go along. Yeah. So you have the mark here. Okay. Pull some more. Leave it. Okay. So this is a very important step. It's already split because if you don't take care of this step, this button can go out of the tensor fascial lata and split, or it can go out of the skin. And button sometimes even can come out of the skin if your assistant pulls very vigorously. And so this is how actually the mark is. I think maybe tunnel length is not 35, maybe 32 or 33. You can see the mark is here. When you pull it, you can see this is solid. It doesn't move. Sometimes if it flips under the tensor fascial lata, you will have a spongy effect. It goes up and come for at least 5 mm to 1 centimeter. That means you are not out of the pars cortex. You went out of the fascial lata. So the two way you can confirm it whether the pull and see whether it's in the bone, or you can also flip that your blue and tiger, and you can flip and see whether it is confirmed or not. You can see that our Venugopal is doing that flip. So you can feel the flip like a fixed button. You can feel the flip. Okay. So I have flipped it. So now I pull the graft. You can see that two white tapes there, suture tape. Okay, go ahead. So he is pulling that graft inside. So that is the mark which I required. 22. Tighten up. Okay. You don't have the most
Remember, sir, there is one question. If you have a accidental posterior blow, how will
sorry.
posterior blowout? So what are the blowout options?
Normally, I don't use the aggressive shaver for the graft. There is another smooth blade which can be used to clear all the other soft to show it better. Anyway, come back again with the question, Rajiv.
As a question and house, if there is a posterior blowout, what are the options?
Oh, okay, blowout. Okay, the blowout will not happen for entire tunnel. You know what I mean? So usually the blowout, if it happens usually maybe 5 mm or 8 mm in the entry point. Okay, so you don't blow out of entire 2 to 2.5 centimeters. If you are very careless, you can take 3 or 4 mm in the posterior cortex. So bailout option is that you ream more. You suppose you ream the other, you have another 5 mm in the posterior cortex intact. You can ream another 5 mm more and you can take the graft longer. But at the time, make sure that your graft you have enough length. Then if you don't have enough length, then you may augment with another graft or make it as a 5 strands like this. Especially if you are using a 4 strands, 100% the length is not sufficient. So you have to make it as a 5 strand, or another bailout option is you can take a Polonais longus and make it longer and put it there. Okay?
All right.
You do the cycling at least for around 15 to 20 cycling. So make sure that the tendon is getting, your graft will get some tensioning. Then after doing that, so make sure that again you take that tape and tighten it so that there should not be laxity, because adjustable loop, that is the only problem. Which people think that it may get loosened up, then problem. So keep it around 30 degrees. I don't give much posterior push for my graft fixation. Can you show the outside view?
So how do you decide about the diameter of the screw on the tibial side?
In general, if the graft is nicely fixed, snugly fitting with the channel, then normally I use one size more. Suppose it's 8 size, usually I use one size more. If it is very snugly fitting, if I feel very tough, sometimes we don't use sometimes 0.5 mm increment. When you are using 1 mm increment, sometimes you feel that graft is very tight in the tibial side, it is not going. Then I will use the same size of the tunnel which I made it. Like if I made it 8, I use the 8 size graft. And that can be easily, you can elicit by putting a small hole between the graft and your tunnel to know how much the space which you get for your screw. So it is not very tightly, snugly fitting graft. So I'm using one size more. I'm using 9 to 28 here. But if you have a doubt, you can also measure the length of the tibial channel. You can use if you have the measuring device, you can measure the channel. Then depends upon that, you can use 28, 30 or 35. She is a small female, and I didn't measure it, but I know that it will come around only 28 or 30. So I'm not using the longer one, 35, because if you use the longer one, then the tip of the screws will come inside the joint.
What is the position of the knee and position of your guide wire?
It is around 30 degrees of flexion, knee flexion. And my guide wire is posterior to the graft. So I try to go posterior to the graft all the time. Because if you go not posterior and distal, so you get the bone quality is better. If you go more proximal, close to the tibial condyle, anterior to the graft, then the bone is very cancellous. So the grip may not be very good. You can see the sound. Like if, I don't know whether you can hear the sound. There is a very nice grip here. Can you see that?
Yes.
I think you can see that outside view. So that is, I got a very nice sound. I can see that still the graft is outside. Can you see that?
Yes, it's
I
outside.
have another 1 centimeter outside. That means you are safe. Suppose if you feel that it is little shorter, your graft is not coming out of the outer cortex, the length mismatch, always you can augment with another fixation like suture button. Okay? Okay.
Inside picture, cameraman, inside picture.
Can you show the inside picture?
Yes.
Can you see that?
And yes, it's picture. We can see graph is tight.
You can see the graft is the orientation. This is how your entry point should be there. It's not making a very vertical graft. This is how the transportal technique. It gives you the normal ACF. You require this kind of laxity. Okay, you don't make a very tight graft. So you can see this with a very good tension here, and do the extension slowly. And especially when you are making this transportal with low femoral tunnel, you never get any impingement. So this is in a full extension. You can see the graft. Gap between the knot and the graft. Okay. I think that's all. I think it's done. Any questions, Raju? If you want to have any questions, I can answer. Otherwise, I have nothing to do here.
So thank you, sir. So wonderful demonstration of facial reconstruction. And so much of side. Randa, we can go back to.
Thank you. Thank you, sir. Thank you, sir. Nice to meet you. Thank you.
Delegates, you can have any questions right now because Sagar is there, we are there, and we can answer those questions.
Thank you.
Regarding your question, sir, how to reach the posterior medial area when the ACL is intact?
So there are certain manuals. The easiest one is you can remove some part of the PCL side. You get a better space. It's a manual known as Gilchrist manual. So what you do with the one portal is anterolateral portal, you need to place a messenger wire, which should angle and reach posteriorly, over which you can slide your cannula, and it's an easier trick. You should be able to reach it in slightly with the knee slight extension, not a 90-degree flexion. So these are certain tricks which help you reach that posteromedial corner in a better way. And I think safest way use your switching stick, because you will not cause any damage to the PCL also or cuffing of the cartilage. And that is the switch monitor. The virtually in the posteromedial compartment, we just move your scope in the horizontal direction, left and right, and you can see whole of the posteromedial capsule. Yeah. So I think transeptal portal, Yusuf, you want to take this question?
Transeptal portal, we have to see when it's required. Most of the times it's not required unless you're looking some ACL avulsions where you want to take some bite. It's very viewing, so it's an outside and portal. So you just need to pass like how you pass for the anteromedial portal, pass it below the patella, go through the patellar-tendon, and you can reach it. So that's what you're asking. He's asking the posterior.
So transeptal portal has been described for PCL reconstruction, remnant preserving PCL reconstruction and PCL avulsion. So once you are inside the knee, you have an intact PCL and intact ACL. The interval between the ACL and PCL is your intercruciate interval. We call it intercruciate interval. Just put your saber blade there. You can palpate the interval between the ACL and PCL. Keep your blade upward towards the roof. So that is the central part of the septum. Just divide it. And then put your scope on the posteromedial side. Through the posteromedial square, you are viewing that you can divide whole of the portal. The advantage is that vessels are 15 to 20 millimeter back. Once you release this portal, your vessel goes 30 millimeter back, 20 millimeter back. So you scope bundle far away. Second thing, because if you want to take a bite to the PCL average fragment, if you make a transeptal portal and posteromedial posterolateral side, you can just switch on your PCL with the bony chunk nicely. Sagar, you want to add something? So, main trick we should do is the most important part is you have to visualize from anteromedial portal. So that you get a direct access from anterolateral and you show it doesn't go in the substance of any ligament. If you're trying to do it with anterolateral visualization, it always is a difficult job. Always. Try to be close to the bone. When you are making your PCL tunnel, also try to be close to your bone. Don't use your suction pump and try to keep your blade always towards the posterior body of the posterior surface of the tibia. And these are the safe, I think, maneuver by which you can protect your neurovascular bundle. Chances of injuries are less. Sarfaj, you want to add something? Yeah. Okay.
I think visualization of the PCL and the portal, most you can see it's always difficult to see the structures, and once we can see the structures, the rest of the thing falls to place.
So once this is a situation where the single bundle is there attached, is little bit lax. Now, whether to go parallel to that or whether to shave that is a very difficult situation.
Partial. Sagar? So, yeah. So it's if it's a even bundle which is there and it is lax, I tend to remove it and then reconstruct it with a thicker graft. I don't think these bundles function in a proper manner. If you have a posterolateral bundle which is lax, I don't tend to remove it. Just do a reconstruction like augmentation for the anteromedial bundle. Parag, partial ACL, how do you?
Most of the time, actually, we need to see which bundle is affected. If the posterior lateral bundle is intact, then we can augment it. And if the anterior medial is intact and posterior lateral is gone, then it is better to reconstruct it.
So what I do normally, I put after saving the torn part, the intact bundle I put and see for the integrity. Most of them, you see, a thin band is attached over the femoral side. As Sagar told, if it is a very thin band, if you see one of the bundle is intact, then you can plan for a ACL reconstruction and try to make your tunnel away from that bundle so that you are not damaging. But it's very technically demanding. Most of the time, when you make your second tunnel, indefinitely you will damage some amount of your ACL fiber which is attached over that footprint area. Iranda?
I think everything is covered. So regarding only thing this transeptal approach, sometimes you can just put that from the posterolateral port. You can put that Wisinger rod right to the posterolateral port, and then you can have a posterolateral entry point also, and then you can one can be a viewing portal, the other can be your working portal. That also you can do. If you are doing PCL avulsion, it's particularly helpful.
And in our setup, actually, if the partial ACL tear is diagnosed arthroscopically, I think it is better to reconstruct it because we get very little chance for second option. So that's why it is better to go for reconstruction, I think.
Yes, if this ACL is stressed out, is actually a non-functional ACL. But then that's what you need to see the integrity of the ACL. If it is, as everyone has said, if you think that it is a non-functional ACL, better you replace it. I mean, reconstruct it.
I think yes, we will go with it. Yeah. Coffee break.
Yeah, just a quick coffee break. I won't give you 15 minutes because we're running a little late. After that, we will come up with the other lectures. So 10 minutes of coffee break. Yeah.
I would request everyone to take seats. We will start again. To chair this session, I would like to invite Dr. Chinmay Das and Dr. Okay. Yeah, everyone please have your seat. We'll just wait for a few seconds because we generator pickup, so we do not want any pickup during live surgery. We'll switch to main panel now.
You want it to be switched off? This one?
Okay. I would like to request Dr. Chinmay Das to chair the session and also Dr. Qasim Qasim Ahmed to chair the session.
Good morning, everyone. So we are going for the session 3. I welcome you all. So in this session, we are having 3 presentations, one by Dr. Sagar Kakatkar from Nasik, second by Dr. Rufus Vasantaraj from Chennai, and third is from our own very own Dr. Rajiv Raman from West Bengal. And we will have questions after this thing, after the all the presentation with felicitation of the speakers.
Thank you very much, sir. We had a wonderful live surgery, and now we shift our focus to a completely theoretical talk, but an important one, that is fixation options or modalities in ACL reconstruction. Which is better, aperture fixation or a suspensory fixation? There's a wonderful statement by Brian Cole That is, much more is known about the biomechanics of these fixation methods than the clinical consequences or significance. Both biomechanical and clinical significances of these fixation devices are important. So, what are actually the two kinds of fixations? A compression type fixation and a suspension type of fixation. A compression type of fixation is the interference screw fixation, while the suspensory fixations, as was wonderfully demonstrated today in the live surgery, was the femoral suspensory fixation. What are all devices that are available for the fixation of ACL grafts? We all know the interference screws, which come in different materials. There are cross pins available, which are expandable, non-expandable ones. The commonly used suspensory femoral fixations, such as rigid and adjustable loops. You will have steppers, suture posts for the tibial sided additional suspensory fixations. What is important in choosing your fixation modality? So you have to know how the graft incorporates. That is definitely different from the rotator cuff repair. A rotator cuff repair also is similar. You are reattaching a soft tissue to the bone, but it's a surface integration. While in our ligaments, it's a intra-tunnel integration of the graft, which we are looking for. It is the recreation of enthesis, which is important. So there are three basic phases of graft integration. In first 2 weeks after your surgery, there will be a phase of necrosis and a formation of disorganized granulation tissue. It is important to note that histological studies have proven that the necrosis starts at the edge of the graft and then goes to proceed in the center of the graft. At around 4 weeks mark, there is a formation of fibroblast, a rich connective tissue matrix. This connective tissue matrix is also disorganized. It is not a classical Sharpie's type 2 collagen fibers. So your graft is still not secured. So for first month, your graft is in danger if the patient lands up with some abnormal activity. At 6 weeks mark, there is increase in type 2 collagen, that is Sharpie's type 2 kind of fibers, without complete reformation. Extremely important word, it is without a complete reformation of enthesis. So your ligamentization has not occurred completely by 6 weeks mark. These all things are important when we consider your fixation devices and your physiotherapy protocol for your patients. What are the biological differences which have been proven for these two fixation devices? So if we see at 6 to 14 months mark, the granulation tissue which is occurring at the aperture or the tunnel at the femoral side or tibial side, if you are using a suspensory fixation only on femoral and tibial side, there was only granulation tissue or a woven bone formation. There was no Sharpie's type 2 kind of fibers which were there histologically. In 14 months. So if you are using only suspensory kind of fixation on the femoral and tibial side, these are the studies which were done in bovine models. The historical studies showed that there was no collagen formation if you are using only suspensory fixation. While at 24 weeks, that is 6 months mark, with the interference screw fixation, because of the compressive effect of the screw at the tunnel, the collagen fibers formation was better, the ligamentization was better, and so was the graft integration. So definitely the interference screw or the aperture fixation proved to be a better tool to get the ligamentization of the graft. So that was the first and most important histological study. The interference screw fixation. What it does, it engages the tendon with the screw heads or screw threads. The kind of fixation strength depends on the pitch of the screw, the kind of the screw, the length of the screw, the diameter. Increased pressure at the tendon cancellous bone junction is achievable easily with the interference screw. You can press fit the graft at the bone tunnel, which increases the chances of healing. If Unfortunately, the patient has low bone mineral density. There are studies which have proven that this fixation can lead to failure. So graft failures have been reported in case of poor bone mineral density in which only interference screw or aperture fixation was done. The factors which affect the interference screw fixation construct strength. If your screw length is less than 23 millimeters, there are higher chances of pullout. Diameter of the screw which you are putting. So if you are using a soft screw, a bias screw, or a resolvable screw, try and put a screw at least one size higher than the diameter of the graft. If you're using a metallic screw, try and put a screw equal to that of the graft diameter so that there are lesser chances of graft cutout. The structure of the screw is also important. Sometimes the screw might not be a tapering, or sometimes the screws which are tapering. So how to differentiate, or which screw to be has to be chosen? So the screws with tapers tend to keep the graft integrity intact, but they have lesser hold at the aperture. Position of the fixation also changes the graft screw dynamics. There are certain new studies, these are all studies published in year 2022-23. Nowadays, they are working on having magnesium integrated screws, which have shown better integration. These screws are yet to get in the market, and we need to see what are the long-term effects. Suspensory fixations such as fixed loops or adjustable loops have been proven year on year. There are studies which will say that fixed loops are better suspensory wise, or adjustable loops are better, but recent published 2023 New Zealand data registry showed that there was absolutely no difference between the fixed loop and adjustable loop devices considering the functional outcomes at 6 months mark. The suspensory fixation allows micromotion of the tendons, such as the windshield wiper effect, and it can lead to widening of the tunnels. How much it affects clinically, we are yet to see. There is increased synovial fluid seepage, which can interfere with the graft incorporation with the suspensory fixations. But since it's fixed on the cortex, there are lesser chances of graft getting pulled, except if you're using the biopins or suspensory pins, when there are chances about 23% of the grafts were getting pulled. So with the transfixation pins. Like I just said, there are n number of studies published, few in favor of suspensory, few in favor of interference screw fixations, but recent meta-analysis have shown that there is absolutely no difference if we consider the fixation devices and functional outcomes. What we saw today was a hybrid fixation, that is a suspensory kind of fixation on the femoral side, followed by an interference screw, that is the aperture fixation on the tibial side, which is what most of us follow. We have got excellent functional outcomes with the using of the same. Sometimes you have to go ahead and do a dual fixation, which I usually do for all my PCS. That is, I put an interference screw on the tibial side and again reattach a suture post for the tibia, which is to get a better security that you will have lesser chances of graft slippage. There are studies which show that there is implant-less fixation. These are a kind of fixations where you get a hollow meal kind of devices to pull to get bone tunnels, get that bone graft out and use that to fix your graft. We are yet to see long-term outcomes with these. Thank you.
Thank you, Dr. Sagar. Now we invite the next speaker, Dr. Rufus Vasantaraj from Chennai. He will be talking on all inside ACL reconstruction, when and how.
Morning, everyone. I'm going to be talking about the all inside arthroscopic ACL reconstruction. So it's been there for quite some time, but I'm very sure most of the people don't do it. So coming to the topic, what are the different things which we do in all inside ACL? The graft preparation is different because we use a technique called as graft link. And we use a specialized instrument called as flip cutter, twister, or a retrograde roller, depending on the company. And we do an inside out tunnel drilling. And the graft passage is actually through the portal and not through the tibial tunnel. And both sides we use a suspensory fixation. So this is how a graft is prepared for a all inside ACL reconstruction. You require only the semitendinosus. You don't require a gracilis. That is the first biggest advantage. So you take both the ends and put one hand through both the suspensory fixations. Excuse me. And then take it out. So keep both the open ends together and stitch it. So once you stitch it, just make sure it becomes a four-stranded graft. And the open ends, try to push it inside so that the outside end of the graft looks more comfortable and more smoother without any much of damage. Then you take a bite through one side. Okay, if you're taking from the, let's keep the superior part, take it from there and then take it in a reverse manner through and through on all the four strands. This is a specific technique, it's called the graft link technique. Then reverse manner through all the four. Then tie it around. Then now exactly these two sides of the strands which were not taken in the first time, and then tie it together. And take it out so that there's no any loose ends. So basically, since it's a suspensory fixation on both the sides, the length of the graft required is very less. If you see, we require only 20 mm on the femur side and 20 mm on the tibial side, and in between the intra-articular part might be around 25 to 40. So overall, the length required is very less. So most of the times, a semi-T alone is more than enough. So this is an outside end drilling, which normally I don't do, but this is one of the ways of doing it with the help of an instrument, a flip cutter. So basically the instrument goes inside and then you lock it and then you drill it from outside in. So just an animated video of how it was done. I don't use an outside in jig because it makes extra incisions on the femur side, which is not required. We can do it the regular way because regular way itself is all inside only, what we normally do for a femur side. But this is how it has been described initially, and some people still follow this. So you lock it with the jig and then you open the flip cutter and drill it from inside out. The medial portal option is what we normally do for a regular ACL reconstruction. So that is more than enough to do an all inside ACL reconstruction. And this is on the tibial side. So the same thing which I explained. So you use a flip cutter. So the flip cutter goes inside and then opens up. So the flip cutter can be set in different diameters. For example, the graft is 8 mm or 9 mm. You can fix it accordingly and open the flip cutter at that particular position. So it opens up at 9 mm diameter, and then you can drill it from inside out. So basically the outer cortex of the tibia, the periosteum and all is not breached. So it opens up and then drills from inside out. So this is how it looks when you do an all inside ACL reconstruction. Both the sides on the femur end as well as the tibial end, the cortex and the periosteum are not breached much. Most of the tunnels are inside. I'll show you an animated video of how to pass the graft. So the graft goes like through the portal, not from the tibial side. It goes through the anteromedial portal, then you take it out, cinch it like regular thing, and then comes from inside out through the tibia. And again, you do the same thing like what you did on the femur side, here on the tibial side. So post-op X-ray will look like that because you use a suspensive fixation on both the sides. This is how an initial all-inside ACL reconstruction was described. There are a lot of alterations and different ways of doing it. So basically, you can use a femoral and tibial side flip cutters and both sides adjustable loop suspensive fixation. That is how initially it was described. A little bit of modification is that you can augment this with fiber tape and anchors, like called as internal bracing. Or you can use only tibial side the flip cutter and femur side like a regular inside-out technique. And then both sides use an adjustable loop fixation. The problem is that flip cutters are expensive. Sometimes in initial situations or like cases where you don't have a flip cutter, if you still want to do an all inside, there are two other ways of doing it. So basically here on the tibial side, you drill it through and through, like how you normally do it. And the graft comes out, you use a low button tightrope, and then you use a ABS button. So this ABS button is much bigger. So since you've drilled it through and through, it might maximum be 8 mm or 9 mm you have drilled. The ABS button comes in different sizes like 11 to 14 and more also. Or on the other side, just use a fiber wire, whatever is used for stitching, you can just take it out and fix it with an ABS button. So this is also both sides suspensive fixation. It's not classically an all-inside ACL reconstruction, but still comes under the category. So we look at the pros and cons of all-inside ACL reconstruction. In the graft, we take only the CME. So always preserving a gracilis is good for functional outcome as well as for future need. It gives a good diameter. You don't need to be worried about diameter because most of the times when you do hamstrings, a little bit worried about diameter because sometimes it can be less. But when you quadruple it, definitely it gives a good diameter. On the tibial tunnel, the issues with screws, what all issues you normally describe with screws breakage, screws loosening, all those things can be avoided. And the cortex and periosteum are not breached on both the sides. So usually there's a lot of study which says that when the periosteum is not touched, the pain relief factor is very good. And also the bone healing is much better in the tunnels. And graft passage is very smooth. It doesn't go through the tunnel. It goes through the portal. It might not be very relevant, but again, there are a few literature which says that when it goes through the portal, it's much smoother. When it goes through the tunnel, it can still have some damage to the graft. And graft tensioning also is more easier because even after doing the entire procedure, you can tension it on both the sides. The cons are we don't have any long-term studies even now. It's still short-term. The cost factor, of course, increases because both sides suspensory, as well as we're going to use any extra equipments like flip cutters or twisters, the cost increases. And extensive tensioning can cause extensor lag. So the current literature which describes is that you need to do an all-inside reconstruction, fix the tibial side on extension, not at 30 degree of flexion to avoid an extensor lag. Both sides suspensive fixation, you can have all the complications which a regular suspensive fixation can have. Thank you.
Thank you, Dr. Rufus Vasan. So now the third speaker is our very own Dr. Rajiv Raman. He is from West Bengal and he has helped Nerosai a lot. So we are thankful to him. Dr. Raman, please.
So I will be talking on meniscus root repair. In last 1 decade, we are addressing more of the root repair. Why? Because if you see, if you don't address the meniscus root injury, the whole of the meniscus seems to be intact, but it is extruded. And once your meniscus is extruded, your knee is behaving like a meniscectomized knee. So always, when you are dealing with a traumatic meniscus root injury, try to repair it. There are different techniques. I use it as a suture bridge technique, which is so this is a video is not running. Yeah, hopefully. Some issue is there. Just I think I will play it separately. There are some issue with that PowerPoint presentation. So this is a repair of the avulsion of the posterior of the lateral meniscus, root avulsion. And if you see, when you put your scope inside, a 20-year-old guy has a posterolateral vertebral injury, and you can see it's like a Lapide type 3 type of injury. Whole of the root has been avulsed, and you can see a small defect in the tibial cartilage also. So most of the time, we try to repair such type of repair. Yes, you can ignore 1 to 2 centimeter of cartilage loss, because once that is covered up, the healing of the cartilage. The most important point is in acute injury is that you don't have to prepare the cartilage. You just try to pass your bead pin, fire your bead pin through the posterior lateral aspect of the tibia, and pass your suture wire through the anterolateral product. This suture loop, once you have passed it, now you take a bite through the root of the meniscus. You can see this is a self-retrieving suture passing device. You can use it and you take a bite. What I do normally, I take a bite through the drill, over that I pass my suture material. So here you can see, now once you have taken the bite, you use your normal shoulder instrument. The shoulder instruments are always with you. Use the normal shoulder instrument to take multiple notes from that part of the root. And you can see, once we have passed it, and this is the orthocord we are using here. So with the knot pusher, try to put three half inches knot there, so that you have a staple construct there in the root of the meniscus, and pass this through the tibial tunnel. There are 3 important points here. So when you have a injury which is more lateral, don't try to overstress it. You can see I have just medialized my tunnel so that my meniscus is sitting well over there. You can see. So once you tie it over the anteromedial aspect of the tibia, over the suture disc or suture post, all of the meniscus cyst bands, and now it will behave like a normal meniscus. This is very important. So when you are dealing with an acute injury, 3 important points are there. Try to reduce it. Try to reduce it with the anatomical position. If your meniscus is a bit lateralized or is coming towards the other side, try to put it and try to fix the root at the level where the meniscus will be in less stress. Since the PowerPoint is not working, I will show you the separate video. Yes. So this was an acute injury. Now, sometime you may have a chronic injury, medial meniscus, you can see. So in chronic tear, what happens here? You have to, first and most important part is you have to prepare the root, the area where you want to make it on. This is the medial meniscus root avulsion, you can see. So first and most important part is you have to prepare the crater. So try to remove all the cartilage from the slope. Suppose this is a tibia, and here you can see the tibia slope starts. You see in the direction, just as close to your PCL, you can see that is the area which has an anatomical attachment of the root. To try to remove that cartilage, one is important because we want the healing of a soft tissue, so meniscus avascular structure over the bone. So unless you have a wrong area there, it's not possible. There will be a good fibrous healing between the cartilage and the bone tissue. To remove the cartilage here, we are using a normal ACL jig to make our tibial tunnel. And what is important, when we are repairing a lateral root and with ACL, most of these root injuries are with ACL injury. So try to make your tunnel, tibial tunnel, close to the tibial tuberosity for the lateral meniscus root, posterior hand of the root. If it is a medial meniscus posterior, we try to make your root tunnel close to the posterior medial body of the tibia, so that your both tunnels are parallel and you don't have collision of this tunnel. So here you can see. So once you, this is a normal ACL jig we are using. Fire the bit pin and do it under direct visualization, because you have posteriorly you have your neurovascular structure there. And once I put it, you can see now I'm firing my bit pin, and over that bit pin bring it with a 4 millimeter bit. So here you can see, and so once you fire the 3 important thing is should do it under direct visualization. Why? Because sometimes what happens, you have to open with even you are dealing with a root avulsion of the medial meniscus, posterior medial meniscus, you can just put a valgus and a bit of acceleration. You can open the knee, and just you can see you have fired the bit pin over that. Now put your curate there to protect the posterior structures. You can see, and now I am putting the curate there, and over that bit pin I am drilling through the 4mm drill bit. So that is my tibial tunnel. So you can see over that, and always try to use your curate as a protector to protect it, and then over that pit pin, try to make your 4mm tunnel. Once you have made a 4mm tunnel, just pass your suture lasso, you can pass it over the pit pin and park it in the anteromedial portal. So you can see once you have removed it, now you pass your suture lasso and park it in the anteromedial tunnel. Normally we use the colored suture lasso, either yellow one or green one, so that it doesn't it should have a good contrast with the posteromedial soft tissue. Once you can see, I am using the yellow suture here, and I will pass it in the anteromedial portal. So that is my tibial tunnel. Now again, the steps are same as I described in the lateral root avulsion. Try to take the bite over the root of the meniscus through self-passing suture, self-repeating suture passing device, and try to reduce whole of the meniscus over the anatomical area of the rule attachment. Now you can see this is a raw area. Over that, when I will and you can see I am parking it in the anteromedial compartment, and now you can use any of the self-retrieving suture passing device. Sometimes if you don't have self-retrieving suture passing device, you can use a between also that will be described by Pancha et al. To pass a suture through the meniscus root, the terminal of the meniscus root. So here you can see now we have taken we have tied the root with an orthocord, and now once you pass this orthocord over the tibial tunnel, you will get a good reduction of the meniscal tissue, anatomical reduction of the whole of the root over this tunnel. So what are the important steps? The PowerPoint is not working, so I will tell you, I have shown you redirect the video file. First important part is that when you are dealing with acute avulsion, you have a raw bone there. Just try to make your tibial tunnel under direct visualization and try to reposition your root in the anatomical location. When you are dealing with a chronic there, always most of the time you have a cartilage tissue there. Try to reduce, take off the cartilage tissues, because you want a good crater there. Over that your meniscal root will sit down. And then again steps are same. Make your tibial tunnel with a bit pin and 4mm calorical drill bit. Then try to pass your suture lasso. Take the stitch through the root. Try to pass the root stitch over through the anterior middle aspect of the tibia. Again, when you are dealing with a root tear in the posterior horn of the lateral meniscus, try to repair, make the tunnel, the root tunnel close to the tibial tuberosity. When you are dealing with the posterior horn of the medial meniscus, try to make your root tunnel close to the posteromedial border of the tibia. Thank you. Sorry, there was some issue with the PowerPoint.
Thank you, sir, for a wonderful presentation. So, any questions from the audience? So, what is the fixation device you use for this root tears?
Good question. So I use the single tunnel technique. Laprade has described the two tunnel technique, but I think it's very cumbersome. If you are doing a DCL and two tunnels for root, it's very difficult to manage those tunnels. So single tunnel technique, I usually put either a post or a tendon button or a disc over the anteromedial aspect of the tibia. All right. And if you are using post, you can tie your ACL thread also there over this post. That will act as a supplementary fixation.
Thank you, sir.
Any other query? All three together. Sir, if I add to any comments?
Dr. Yeah, he touched upon the healing after the reconstruction. Now, can you guide us regarding the post-operative management in view of the healing method that you take? And we must remind you, or in fact, everybody knows that we are converting a tendon into a ligament. There must be a lot of changes in the histological structures. Just guide us regarding post-operative management.
Yes, sir. Thank you for the question. So this is regarding which was published in 2022. We have studies which are suggesting that we all have been trying to push our patients to do good rehab as soon as possible. We tend to neglect the kind of graft we are using and the fixation modality in most of the patients. in patients, and our usual protocol has been for the physiotherapist, start with quadriceps strengthening, include knee ROM 0 to 90 degree if it's just an ACL in first 3 weeks. That has been the usual protocol which has been followed. So this study actually showed that if you have used hamstring autograft, and if you are asking the patient to push for 0 to 90 degrees of knee flexion, maybe a closed chain or open chain, there are chances that not only the patient will land up with loosening of the graft at the femoral and tibial apertures, but the recovery for the hamstring will be delayed. So the current people, we don't know what the implications of it, but they have suggested that you have to stop the knee range from 0 to 60 for the first 3 weeks. We have been very aggressive. So I have been pushing my patients to get full knee range in first 3 weeks. Maybe suspensory or interference fixation. The second most important part is if you are following the BTD protocol, then you have to follow extreme measures to take care of your quadriceps mechanism so that you get good extension. So if you have a BTD protocol which has been used, ask your patients, consult a physiotherapist to focus on getting the bulk of the quadriceps back. You can use stimulation protocols and routine protocols. Never go for open chain knee range of motion exercises. That has to be a dictum for all your physiotherapists. Never ask the patient to sit by the bedside with his legs hanging down. This is the commonest mistake the physiotherapist will ask your patients to do. So never go for open chain knee range of motion protocols. So for first 6 weeks, when we have at least some part of collagen, maybe disorganized collagen fibers formation, we have to be careful. Reach a 3 months mark. It is a actually has started with the hamstring, and your BTD probably has healed well. So you can progress with extensive gym protocol. Sports activities at 4 months mark, I tend to push for it to 6 months, and contact sports at 9 months. So you changes from that.
So I think he had described everything. The only thing is that important thing is when you are dealing with an ACL. So your rehab protocol should be more concentrated towards the hamstring than the quadriceps, because hamstring is agonist of ACL. So if it is every time you're doing the CME protocol, try to cover 6:4. And what's it for PCL? When you are doing PCL reconstruction, your quadriceps protocol should have use of this mode. So you should move the quadriceps rehab than hamstring, because PCL agonist muscle is your quadriceps muscle. So I always try to sensitize the physiotherapist and try to sensitize the patient also. So which muscle he has to prioritize. Which muscle will work better than the PCL, we have hamstring, and the muscle quadriceps will work better with the PCL. Yeah, so for Meniscus repair, normally stand up for normally extension press for everyone could change movement up to 90 flexion to allow for prevention. So and we start in the session. So let's see Meniscus, because the simulation of the issues there, simulation of the suture material also there. So let's see when we are dealing with the ACL with the meniscus repairs.
Yeah, generally when you do meniscus repair, it's better to keep it non-weight bearing, especially you have to see how you repaired it. If it's a very stable repair, yes, you can go for a direct partial weight bearing, something like that. Otherwise, it's always non-weight bearing for the first 3 weeks, maybe a ROM of around 30 degree. Then slowly make it 60 degree, 90 degree, and slowly gradually increase it. So that would be the better one.
At this moment, I would like to felicitate the other 2 speakers. I would like to call Dr. Firoz Ahmed to come and felicitate Dr. Rajiv Raman with a Salam Gamusa and a bouquet, and of course a moment on an Assam tea. That's fine. Now I'd like to call Dr. Vikas Bodloy to felicitate Dr. Rufus Basant Raj. Yes. It's been a pleasure having you all the national faculty out here today. Bouquet, memento. And a packet of Basmati. I would like to felicitate our chairperson, Dr. Chinmay Das and Dr. Kasif Ahmed. I would like to call Dr. Paragove to give me honor. Thank you so much, Sumada. Thank you so much, Kasif. With this, we come to the end of our session here. Then we go to the next one, which is on panel discussion. I would like to invite Dr. Usi Sama sir to act as a moderator. Can you come? All the panelists will be on that side. Can we have a chair here? Yeah, okay. Okay. So Usi Sama sir as a moderator and Dr. Rajiv Raman, Dr. Sagar Kakatkar and Dr. Rufus will be our panelists. Huh?
Who is talking about what? So you are we will answer. No, I think I will start with a basic outline. Somebody talks about the basic outline because this is something new. So talk about the basic outline and then I think one by one. So let us start the next session. This is regarding multi-ligament injury. It's one of the difficult problems in the injuries. There are different groups, different varieties in the injuries. I request Dr. Rajiv to talk about the basic outlines of the multi-ligament injuries, and then we proceed further depending on the demands of the presentation.
Yeah. I think I'll it's a case-based discussion, sir. I will present a case. Yeah.
Oh,
It's a case.
Yeah.
I'll present a case here.
Yeah. Okay.
We all know multi-ligament injuries are complex injuries, and a lot of confusions are there. How to treat, how to approach all these injuries. I have got very limited experience of treating these kind of injuries. Nevertheless, I took the opportunity. We have some eminent faculty here. We have UC Madatta, so I thought, why not have a case discussion on this? So when you approach, there are a lot of confusions. There is no right answer, the wrong answer. We would like to come to a consensus if possible. There are differences of opinion. So let's go to the case. The case is a 48-year-old male, injury to both his knees, followed a heavy objective granite slabs actually fell into his knees. He dislocated his left knee, which was reduced elsewhere, and there was a common of injury. He came to foot drop. Both knees were multi-ligament injuries. We also had a bilateral fracture right ankle. There were other bone injuries, associated injuries, and there was no arterial injury. And we received the patient at 12 post-injury. That's the background. And if you see the left knee dislocated, it was reduced and elsewhere and then immobilized in a back slab. It was fairly stable and it's not very unstable knee when you receive it. And these are the MRI pictures, and basically what we came to know that it's an acute kidney type of injury, LN. So for the house, and just it is described as per the SANC classifications. KD1 is either ACL or PCL knee dislocation. 2 is bicruciate. 3 is bicruciate plus another either lateral corner or the medial corner. L will denote if it is a 3, that means cruciate gone, and one of the here I would like to call upon Dr. Anil Manka sir, who's supposed to be another moderator. Please come, sir, and join Isu Sama, sir. Give him another chair. Yes, sir. Thank you, sir.
Thank you. My apology, I've been late. I thought it started. Anyway, please continue.
Just started. So basically, when you have apart from 2 cruciates, we have another column or collateral involved to be classified as KD3. If it is a lateral corner, it denotes by L. If it is a medial corner, it's M. And N stands for nerve injury, and if it's a vascular injury, it will be C. So it's an acute KD3LN type of closed injury. So basically, what we essentially have here is a grade 3 BCL tear, grade 3 ACL tear, grade 3 PLC tear. And out of this, LC is a mixed substance tear, and 40% bicep femoris and avulsion. And also here, common nerve injury. So this is a quick examination in the OT. You can see in the extension with the varus stress, it opens up completely. There is anteroposterior stability, and when you try to lift it, it goes into recurvatum, indicating that the posterolateral corner and the ACL are gone. Have that dialysis done here. That should have been done. That's about the right knee, X-ray. It was not dislocated, but you can see here the both sides are sagron fracture, probably a reverse sagron fracture here. So that's how the looks like avulsion so something like that. So so it comes out to be a grade 3 ACL, grade 3 ACL. Grade 3 LC, which is a distal avulsion, a sagron fracture and a reverse sagron fracture.
So even I think let us ask the panel regarding what is their opinion regarding the management. And later on, I think as they finish up, you can tell what has been done.
Later on, I will come to them for the treatment. Before I did.
Yeah, it's started.
Are you happy with this, or you would like to see some other?
So I think you have shown the MRI picture, clinical stages are also there. So it's a KD3L type of injury. So for the benefit of audience, when you are getting a common peroneal nerve injury with a multi-ligament injury, most of the time it's a injury in continuity. So you will not get avulsion of the fragments. So these are the avulsion of the nerve fibers. It's like injury in continuity, and 60 to 70% of them recover in due course of the time. You have to keep them on foot drop spleen. So counsel your patients that you will have a foot drop for 12 to 16 weeks, and by that time, try to rehab these patients. Again, regarding the sequence of fixation, I think you have 2 schools of thoughts. First, collateral or first.
The fixation part later. Maybe I'll come. Thanks, family. Now, do you think anything else you want to say, or you are happy with that?
injury as ghastly as this, always stress radiographs for these patients. I think sometimes overdiagnoses things. For the posterolateral coronal injuries, it's very difficult to judge whether it's a female side or multiple substance injury, because the repair pattern or reconstruction with reconstruction changes according to the site of the injury. So I definitely follow stress radiographs for these. Stress radiographs does it give a clear it does give an idea whether it's an LCL only or it's an LCL with a complete posterolateral coronal injury. If it's up to 7 mm difference compared to the other side, it's only LCL. If it's getting more than 9, then definitely we're looking at a scenario when whole of the posterolateral corner and capsule probably is avulsed. Sometimes the ITB also is involved. Yes. So with this much of soft tissue edema, it is like in the second picture here in the coronal view, it's very difficult to judge whether it's gone or not.
Yeah. So stress view, I think you can, if you see the Laplander article, he described regarding this stress view. So it's always mandatory, not only for posterolateral, if you're dealing with posteromedial corner also, right? I think you should go for this stress view, and that will suggest you it's isolated MCL injury or a posteromedial corner injury associated with MCL injury. So the stress view gives us some clue. So what are the type of injury pattern is there? Right.
Yeah. Definitely X-ray is very important because most of times we underestimate it. Just because MRI is there, we try to ignore the X-rays. Stress views are compulsory for these kind of injuries. Otherwise, you'll miss a lot of things.
Yeah, that's one thing, that stress X-rays, we don't have it, but then yes. Some actually this case for some of the things we had missed, we had stress X-rays, we had some other things also missed it actually.
So one thing you can under CM you can take this view. Yeah. So that is next to it.
So for the house again, we want to know that clinical examination, that's a dial test you can do. You can do the dial test in OT under anesthesia and see how much external rotation and all these things, because at 30 degree and 90 degree, if it's an isolated PLC, then how much it opens up at 30 degree. If it opens up in 90 degree, then you can think that both, I think your PCL and PLC both are gone. So shall I proceed, sir?
Yeah, please. Go for the next one.
One thing I would like to mention, especially in injuries such as this, the dial test which we have been following, it is important not just to check the how much degree of foot external rotation we are getting. It is important to check the anteromedial tibial plateau. Sometimes the MCL itself can give a positive dial test, and we tend to misinterpret it as the only PLC injury. So always check the foot external rotation along with the anteromedial tibial plateau excursion when you are checking for the dial test.
Anything about the vascular study if you want to do anything?
Yes, sir.
Yeah, sure. Can you give the mic to him?
One more mic. So, will the dial test be more informative about the?
So with the fractures, it is going to be positive. Like in this case, definitely it is going to be positive with so much of varus and recurvatum also. If it would have been only PLC also, it would have been positive even without the fractures. But as a protocol, it is always better to check any rotational component which is associated with the injuries.
So regarding neurovascular, yeah. So I think medical point of view for all the juniors in such type of injury, do two things. Do go for the NCB test, document that the common point of the future, other the patient will tell us if it was intact and after operation you have data. So don't foot drop in the acute phase. So document NCB study and always do go for a CT angiogram, because sometimes it's an internal injury. Is found inside. So you if you can ask for these two investigation pre-operatively.
Yes, even if you have received it 12 days, we know that there is no vascular injuries, symmetrical pulses. Even when it's when there is a knee dislocation, it's better to do a CT injury because sometimes you miss those intimal injuries. It's important to document those intimal injuries. We haven't done it, but then it is required. And this just for the house, I'm again telling there's an index called ankle brachial pressure index. And if you can, those patients who have got below 0.9, in those situations, it is mandatory to do a CT angio. I don't know how much we are following, but that's what the literature say. Okay, going ahead. This right knee again, if you see this, it opens up on extension. There is a anteroposterior. So what we essentially have, it's a post 12 weeks post injury, left knee, PCL, PLC, PCL, ACL, grade 3, mid substance LCL, that is, and then the other two innovation, compelling nerve injury, right knee, LCL, distal innovation, ACL, probably grade 3 or 2, maybe 3, grade 3 PCL, and we have second and a reverse second. So how do you plan? A lot of things come to your mind, so
Yeah, it might be an overkill to do both the knees, but unfortunately, it requires a lot of planning in these kind of situations. So looking at the injury pattern, both of them are almost similar. So if you're going to plan for one knee first, like you're going to make it staged, then you have to, in one knee, you have to finish off everything, because it's impossible for you to do staged in one knee and then go for staged in the other knee. Doing both the knees can also be done, but provided for the fact that the patient requires a lot of anesthesia, the tunicate issues, like you might have to,
yeah, a lot
of other things are there, so that is not advisable. So very rarely we come across these kind of situations where both the knees have this high velocity of injuries. Most of the times it'll be the opposite knee might be having just a meniscus or ACL. So if you're taking it stage wise, if you're going to take the left knee first, stage 1, you're going to finish off everything in one shot, it can be done.
So you were going for acute, I mean, one stage left knee,
and then do the right knee later.
Okay. Okay.
I would go ahead acutely for both the knees. My preferences will be, since I might be able to repair the posterolateral corner, primary repair for the posterolateral corner for both the knees, get the knee centralized with PCL. I may not touch ACL at that time. But yes, definitely PCL and posterolateral corner and versus femoris avulsion fixation at the same time for the left knee with common neurolysis at a time.
Right. So you're going to do in the same stage,
Same
stage, but you're not going, I mean, you're going to do stage, but in first stage, you are going to do PCL and the PLC.
Get the LCL, yeah.
Right? Right.
LCL repair and PCL reconstruction.
Okay, so
Yes.
same.
Same.
Dr. Raman?
I think 12 days is a good time when you can plan for repair. So up to 3 weeks, your anatomical structure, you can identify those structure, you can just dissect those structure, the LCL, popliteus, you can repair them. So my priority is for the left knee. If the tunicate time permits, I will go for a PCL first because you want to centralize your knee. Over that, I would like to reconstruct my repair my posterolateral corner. You can repair with augmentation also with your graft so that you have a robust, so that you can rehab them early. And if the patient is fit enough, you can on the same sitting after you releasing the tunicate on the left side, you can plan for right side repair. But yes, if your patient is not, if patient is having some vascular or thrombosis type of issues, all those things are there, you can stay with them after 7 days or 10 days, like we do in polytrauma. So I think PCL plus PLC is like a damage control surgery. You start with and rehab these patients. Most of the time you don't need ACL reconstruction because sometimes the knee is stiff enough after multi-ligament injury.
Yeah, okay.
Yeah, I would say, of course, I'm nobody to give an opinion right now, only to guide. But then you do say late reconstruction of the ACL, late reconstruction of the PC, and also the posterior ligament complex. Now, why not put the lumen plaster, wait for the capsule to heal, the posterior capsule, medial capsule, lateral capsule, whichever has torn off, and wait for the surrounding structures to get and do a secondary reconstruction of the ligaments.
Very good question, sir. I think this was a school of thought, and long back we have been doing our residency also. But nowadays, sir, since stiffness and all this component, because repair is always better than reconstruction. So in acute scenario, we don't prefer to do the first 5 days or 7 days. Let the knee settle down. But if you can repair those structures, sir, you can repair it in an anatomical position, and chances of stiffness is less. And because of the new cell implant and new materials which are available, we can rehab this patient very fast if we can repair or reconstruct it within 2 or 3 weeks. So now in multi-ligament injury, for the last 10 years, we are more aggressive in repairing them and rehabilitating them. Yeah. So, yes, sir, please.
Yes, sir. Yes, go on, please.
So regarding capsular injury, sir, there is always a capsular injury, whether it is whenever you have PCL or PLC injury. So normally we try to do it after 10 to 12 days. The only issue is that when we are doing PCL reconstruction with a capsular injury, chances of development of compartment syndrome is there because of the risk of seepage of water in the invoke-out.
Probably there is
Caution you can put autoclave bandage or something in the proximal part of the calf, and in between you can see the tension of the calf also. So most of the time we have done this in acute scenario. The development of compartment syndrome is there. So be cautious, see the pressure of the compartment in between, and try to put a compression band in the proximal part of the calf. That will prevent. I think your concern is more of the compartment syndrome. You are doing arthroscopic PCL.
So we have here a little bit of divided opinion. One is acute 1 stage, and someone is for acute 1 stage, but it's not ACL on the 2nd stage. And then as Sir said, it's a delay, maybe 1 stage, sir, delayed 1 stage. So wait for 3 weeks, let everything settle down, and then we come over again and do all reconstruction, everything. Because if you cross the 3 weeks line, perhaps repair is not possible. In that situation, you have to do reconstruction. So anyone for staged, yes, Dr. Products for staged. So what do you do in staged? So PLC and PCL together, and then ACL later on. Okay, so which one will you do first, PLC or the PCL? PCL first. So then so you want to do PCL and then go ahead. But there are issues here. You have to be quite competent enough to do both the knees under clinical time, because both the knees you have to do. So if you're in a setup where your teammates are, I mean, they know everything, and then they give you everything fast. That's the one thing to do. Okay. Can it? Yeah.
Just a comment. I was fortunate to be with Professor Laprade when he had operated on a skiing injury before of multi-leg KD3 both. So at that time, I was surprised to see that he had done only PCL reconstruction through a PLC. He did not go with arthroscopic PCL. So the TBL direct visualization,
yes.
That is
so you can see
everything.
Yes. So that is another option that you can do. Even may not do arthroscopically, because the posterolateral corner is open. So you can very well put your I mean, you can do an open PCL reconstruction. Yes. Everything is open. Everything is open.
Why do you need a scope? Or actually, you cannot put the fluid in.
Yes. Yes, sir.
We had some cases where I think.
Anything to do with second fracture? Does it influence your treatment? Anyone? Yes, I mean, does it signify anything? I mean, you see that there's a second fracture. Basically, what is second fracture is that? It's your anterolateral instability. It indicates if there is a second fracture, there is an anterolateral instability. Probably it indicates that there is ACL which is gone. So probably your ALL, anterolateral ligament, the concept of ALL is there. So ALL is probably also gone. Should I proceed? Yeah. So challenges are many. These are complex injuries, difficult decision making, timing of the surgery, as we have discussed, whether you want acute 1 stage or delayed 1 stage, and then which order, which one will you do first? We have discussed it. Both limbs you would want to do together or one at a time. Or you want to do repair with augmentation, or reconstruct, which one you want to do, and the choice of graft. Now again, repair with augmentation and reconstruction.
So I think repair 2 weeks time, I think you can go with repair. Repair with augmentation has always been good because you can rehab them early. So The only challenge in this patient is because you have to take graft from one limb. You can't take graft from other limb. Other limb has also here. So one limb, one graft. So if you can repair it, you can augment it. In these cases, in ACL, someone is asking for augmentation. We can use the fiber optic or fiber tape, or we can use some synthetic material for augmentation because you have scarcity of ligament here. Again, so same. If only if this patient would have had a vascular injury where I needed to put a joint spanning hinge external fixator, then I would think of going for reconstructions for all of them. But then graft availability would be a big issue.
So what graft are you going to use for PLC, PCL and ACL?
So PLCL for this patient, I would have preferred repair. PCL, semitendinous and gracilis autografts.
PCL.
PCL.
And
in future for the ACL, if I would have gone ahead with BTB.
and PLC? PLC only repair
Repair.
or only augmentation? Okay.
Whenever I do a repair, I always augment it. So PLC, I would prefer a repair with augmentation. My graft choice is a little bit different. I would do a hamstring for ACL, and for the PCL, I'll maybe use a peroneus.
Right.
I use a lot of peroneus.
And augmentation with the PLC with?
PLC with tape. If you're augmenting with the repair.
Only tape.
Yeah, yeah.
Okay, okay. Okay, let's see. Okay. So what did I do? So I thought about stage surgery here. Because the way I work here with myself only knowing most of the situations here. So I feel that I won't be able to finish up this patient doing acute one-stage surgery. So I thought I'll go for repair, as everyone has said, probably with augment. So I did augment with a figure of that with gracilis, because it's a big man. I will show you the pictures. It's a kind of a modified Larsen procedure which I did. And since the emulsion repair of the biceps femoris and the popliteus, I repaired them. And all the postvertical capsules were repaired. I did the neurolysis of the CPN. And I thought I'll do cruciates at a later stage. So this is it looks like this. It opens up everything, the postvertical corner. As you can see here, that's the biceps femoris getting avulsed. That's a common peroneal nerve getting stretched here, but it's a complete common peroneal nerve palsy, both the complete loss of sensation and the motor. And you can see the LCM will substance and the postvertical corner opens up here. What I did is modified Larsen technique. As gracilis was quite good. I thought like I will use the gracilis and keep the CME for other reconstruction. Fibular tunnel, and then there are two limbs. One limb will be act as a popliteal limb, the other as a LCL limb. So pass it through the between layer 2 and 3, and then that's the popliteal sulcus where I put the first guide wire. And you have to be careful when you go guide wires. The second guide wire is that isometric point for the LCL, which is around 18 mm. It's more or less 18 mm. Proximal and slightly posterior to the popliteal sulcus area, but that will be the socket for your LCL limb. And you have to be very careful while putting this, because you need to do the ACL and all these things might come out on that area, so you have to be quite anterior direction. And since I told using a tightrope for the LCL limb, so I went with 4.5 mm 3 and 2 ring. And then I made a blind socket in the popliteal sulcus where I tried to put that. It's a blind socket, that's the popliteus limb. And then that is fixed it with a screw there. And then the LCL limb is being passed underneath that IT band and your biceps femoris. And then since I'm going to use a tight rope, it is just folded over the tight rope, and then the stitching done onto itself. Then the tight rope RT is being passed through the tunnel to the other side. Once it crosses, once it flips, then you do the shortening. As you can see here, and they milk the thread so that you adjust the loop, and then you can shorten the loop. And according to your desired tension, centralize the tibia over the femur and do the tensioning accordingly. Since we are not doing PCL at this moment, centralization becomes difficult, but that's how you have to hold it and do it. So that's how it looks. So I thought it's better to augment because the tissues look quite shattered. And as you can see, after the reconstruction is good stability interposteriorly. And also you can see that everything other structures are repaired, the biceps femoris, the IT band, and posterior capsules, everything being repaired here. And after the surgery, you can see that quite a good stable knee medial-laterally. For the right knee, again, I thought about stage surgery. Since I saw a Sagon fracture, I thought his ALL is gone. So I planned for the ECL, LCL, and an ALL reconstruction and repair with gracilis. I did augment with an internal brace there. And the Sagon fracture fixation with a CC screw and all other capsular repair. And second stage, again, a cruciate. So as you can, I was talking about the ALL. That's the ALL. This has now been, then many literature have shown that it's a distinct entity now. That gets attached from the LCL, just anterior to the ACL in the femur, and gets attached to the proximal lateral tibia between Guwahati's tubercle and the fibular head. And if you have a Sagon fracture, then probably this ligament is injured, and probably your ACL is also injured. And you can see the Sagon fracture here, and you can see that whole anterolateral part gets opened up here. So, and you see that LCL distal avulsion, but the tissues don't look quite good here. So I don't think that can be repaired. So I plan for again reconstruction here. So there are again two limbs, one for the ACL, LCL, the other limb for the ALL. So the tubular tunnel, the one limb is fixed to the tubular tunnel with a screw, and then the other part is folded over to the other ligament. And over a tight rope, it is folded over, and then two limbs are fixed in this way. That's the guide wire between Guwahati's tubercle and your fibular head. That's the area where the ALL usually gets attached. So that's where I put my ALL limb and use the tight rope to give tension of the ligament, the isometric point of the LCL insertion in the femur. That's how it looks after repair. All other that's the Sagon flexor fixation with a CC screw, and it fairly looks good on table. Okay, so so far I have done this. Any comments or anything you would like to add or maybe modify?
I think the one structure we have to do earliest is the PCL, because unless you otherwise put them on PTS support base. What happens when you repair the collateral and your PCL is not there? The collateral is going to stretch. So again, it will give the secondary laxity in due course of time. So earliest you can do either same sitting as in same sitting you could have done an open PCL also.
PCL also, yeah.
So that could have centralized you then ACL. Most of the time we don't need ACL reconstruction in those cases.
Sir, very neatly done case. It was extremely difficult job. Sir, two things I would like to say. When reconstruction and not centralizing with the PCL, there are certain things which can happen. Like most of the posterolateral column injuries get fibrosis later on, and it's a kind of malalignment which we get because of the tensioning. So if you have PCL, it is better to provide tension in the graft. It is better to put an IV underneath the graft just to keep that minimal laxity on the posterolateral side, so that after fibrosis that doesn't scar it. You have to be careful while giving tensioning here. Yes, right. And like AJ said by Professor, you don't have to angle it just proximally.
Right.
Yes, sir. But nicely done, sir. Yes.
It's a nicely done case, sir. So I would also go with the same concept that PCL has to be done. Otherwise, it's always a problem. And as Sir mentioned, most of the times you don't do ACL because all these cases actually post-operatively don't develop instability. They actually go for stiffness. So it might become really stiff. So ACL might be avoided also.
Right.
But PCL has to be done.
So PCL at the first stage along with PLC would be the best way to go. Yeah, I do.
Very nicely.
Fantastic. Thank you. So that's why we're discussing. That's why we're discussing like what could have been better. I learned a lot through this case. So maybe next time when I do, I'll do a PCL. But my concern was doing so many things together, and the tourniquet time and with my staff. So I was thinking, let's do one at a time.
Just one suggestion, whenever you are dealing with multi-ligament, you try to harvest your graft without tourniquet. You save tourniquet time. Huh?
Yes.
So you save half an hour, all the graft areas, quadriceps, whatever graft beauty without tourniquet, and then start your procedure with the tourniquet. Then you save time.
Right.
Very primary repair of the cruciates. Give us the idea how to do one, where not to do, and put.
Yeah. So I think all avulsion, you have to PCL avulsion, you have to do primary repair. PCL reconstruction, again, there are two school of thoughts. Iranda has done. Some people do collateral first, wait, rehab this patient, and then go for centralization of the knee. So it's a standard procedure. That is also followed worldwide. Or there is a second school of thought, centralize and collateral and go for cruciate. And cruciate, again, if ACL is avulsion, then it should be done in acute scenario. So all avulsion done.
Avulsion need repair.
So far as the femoral end is concerned.
So for femoral, again, we have controversy. Now we are doing for PCL and ACL repair because good instrumentation has come with the civil biologics and all those lateral ankle. You can repair it, but again, you have to be very slow in rehabilitation. So acute case, first 2 weeks, you see good draw margin, type 1, type 2 type of injury value. It's just a whole of the ACL has advanced from the femoral side. You can repair. I think femoral side in the market. So let's see how the result works in this 2 years.
So two things I would like to comment. If you have injuries such as this with posteromedial corner, posterolateral corner, ACL, PCL gone, it is always better to do surgeons with leg in hanging position because the gravity itself gives the alignment for the leg. If the leg is grounded on the table, sometimes it only is contribute factors. So that's the best way to do. Second, the most important thing, like we had a female sided LCL avulsion there, and even the distal side was not very nicely seen. So it's a general trick of the table. So if you are not able to find exact side because your ITB is gone, LCL is gone, WTC is gone, and you have associated bone injury, if you are keeping the knee in 70 degrees of flexion, then the central axis of the fibula will correlate with the femoral attachment of the LCL. So if you are able to palpate for the popliteal sulcus, if you are not able to palpate it, just you can follow this landmark.
Right. So points taken. So second stage, I after about 8 weeks, where after a good range of motions, I did left knee. I did all inside PCL with peroneus longus with internal brace, of course, and both side is a suspensory fixation. Right knee, again, I did the same thing. So anything, I could not complete. I was again standard with tourniquet time, so I thought I'll do the ACL later on. Left knee, ACL was badly gone, but the right knee, surprisingly, has right ACL looks quite good, and I thought probably I will not do ACL anymore in the right knee, as it looks good, stability is good after PCL. So I thought of not doing anything on the right knee. Left knee, after two days again, I took him up and I did an ACL reconstruction with CME and internal bracing augmentation with suspensory ligament both sides. And this is how it looks, the intra-articular pictures. I'm sorry I don't have those right knee. I had to find so many things. And this patient also had ankle fracture, so that was fixed this way. And that's the 3 months after the surgery. You can see that patient could walk. And you can see the range of motion.
that's a 3 months post the last surgery. Consider
Super functions.
and that's about 1.5 years time. I just asked him, you send me some videos, so he sent me this. So that is 1.5 years. He's been walking like this without any support.
Recovered.
Not fully, just partial recovery. He is wearing a dynamic splint there. And he's back to his normal activity. He can even drive. He can ride a bicycle, the motorbike. So he's doing everything. He's very happy. I'm also very happy. Because these are not very common injuries and these are not very regular injuries. So we getting, and I was not sure what to do with the second fracture on the reverse side. Would you have done anything for this?
So
Because I think that again, so there is a capsular ligament.
yeah, but I think we leave it like that. I usually leave it like that. Yes. Same.
Leave it like that. I also left it like that. So that's the X-ray now. The second fracture is still there. The fellow looks stable than the knee, both sides. And he's back to his normal activities.
Well planned, well executed.
Thank you. Anything you would like to add, sir?
Thank you. Thank you, Iran, for the nice presentation. And only thing, the discussion that you have for the youngsters, the new generation orthopedic surgeons who are trying to specialize on this. Only thing I will point it out to you after the discussion is that, number one, station the clinical examination on your clinical equipment rather than going for straightway investigative reports. That was stressed, that the stress test on the OT is more important than the MRI report that has been presented to you. Second, the centrality of the PCL has to be realized. And as I said, that centralize the joint, then subsequently peripheral injuries will be taken care of. Thirdly, point is that rehabilitation is the key to success in clinical practice, not your clinical measurements or radiological measurements. That is the stiffness of the joint, gaining the range of movement, the functioning outcome of your treatment is more centrality of your practice or your aim than rather documenting that sort of activity. But at the same time, talking about documents, yes, documentation is the key in clinical recording that the injury to the nerve, possibility of the block in the artery, which is clinically not evident, but subsequently cause the problem that has to be documented by angiography, as you said. So documentation in the days of litigations, the days are coming. The other generation has been lucky to escape it, but you will not be able to escape it. The American system of the ambulance scissors are coming. It has already come, definitely. So be careful about that. That is the only message I would like to pass. Thank you.
Sama sir?
Have anything else?
No.
No.
Your final thoughts, sir?
We conclude this session.
Yeah.
And what is next?
I think
Workshop.
we have the workshop. Just for the house, when you have acute knee dislocation or multiligament injury, if you have to give you a kind of a treatment algorithm, so what you need is what Montosa has rightfully stressed upon, clinical evaluation, and this is very, very important because it gives you a lot of clue. And then the radiographs are required, stress radiographs and all. Reduction, if it is not done, because many a time these injuries are missed because of the spontaneous reduction. And that time, and also the vascular part to be many a time missed, because there are many internal injuries which we may miss. So after that detailed evaluation, including the vascular study, now it falls into two groups. One may be requiring an emergency operative treatment, the other is the acute phase treatment. Emergency operative treatment, if there is a irreversible knee dislocation or the open knee dislocation or the dislocation associated compartment syndrome, vascular injuries and all. What we are talking about today is the acute phase treatment.
That is within 3 weeks, if you get the patient, what are you going to do? So there could be a three scenario here. First scenario, the single stage, where you do a repair and augmented repair of the collaterals and reconstruction of both the cruciates. As probably, if Sachin Shah would have done that, I think he would have gone for one stage reconstruction, single stage at the first go. So the second option is a stage surgery. You do a repair and augmented repair of the collaterals, followed by the second phase, arthroscopy reconstruction of the cruciates. That's what I have done. And the third stage, you immobilize the patient in the acute phase up to 3 weeks in some kind of a splint, and you do let it heal, let you and you have a good range of motion, let it come, and then you go for delayed one stage reconstruction of everything. That's what probably Ishu Sharma was talking about. So do we have these options? It's up to your expertise, where your center is, how you feel about it, and that's where you have to select your treatment. With this, I conclude, and thank you so much the panelists and then moderator sirs for being with us. Okay. We would like to get take some questions here.
What was the rehabilitation?
Okay.
If it is as you have
Let us hear from the panelists, then.
So, see, normally keep them on PTS brace, and I try to put them on CPM machine because it's a race between stiffness and stabilization. So you have to balance both.
Same. If we are gonna go ahead with knee flexion, either CPM or full knee flexion only, and continuous PTS brace for 4 weeks, at least 4 to 6 weeks.
Okay. So what I did, since I went for the reconstruction with augmentation, I thought it's not like, let's not immobilize it completely, right? Because we need mobility. And it has been shown that if you start early rehabilitation, the mobility is good. It may be a loose knee, but we are going to do reconstruction later anyway. So I started with progressive exercises from the day one. Gradual, of course, keeping the in brace otherwise, but started first week up to say around 30 degree, then 60 degree, then 90 degree, gradually progressive motion as the patient, as the pain tolerated. And then at the end of 8 weeks, I got a very good range of motion. Of course, the knee is loose, that we need. It all depends on your fixation. I mean, if you have done a good job on the lateral side or on the middle side, on the corners, I think you can allow progressive range of motion, right?
Yeah. So I think what Sagar pointed, very important thing, PLC and PCL, don't try to get range of motion in supine position, because the gravity is the most important factor that is going to again make your PCL and PLC reconstructed, PCL and PLC loose. So try to rehab them in prone position for first 6 weeks. Prone position, so that there is no stretching effect over your graft. Both for PCL and PLC, they should be a take-home message. Try to gain range of motion in prone position. What we do in distal femur fracture. So you don't want to stress over the distal part of femur. You try to get range of motion in prone position. Same way, try to get rehabilitation and range of motion in prone position. For PCL and PLC reconstruction or repair.
Is there any other questions? All right. All good. Okay. Yeah.
Thank you very much to the panelists, all the three panelists. Great. So,
thank you, sir.
Learning for both moderator, panelists, and faculty, all of us.
Yes.
they're presenting very good data. So every time you have to so that's
yeah. Yes. We are very bad at doing it. So I could not even find some of the images, see, that's the problem with us, and we have to, we are doing work, but then when time comes, we don't find those. So that's the problem. Anyway, thank you so much. We'd like to go for lunch now. And once the lunch is over, we'll go for the hands-on workshop. Okay, thank you so much.
Not regular, because I keep him coming sometimes. Sometimes we Bhagwan would practice, but this time, you have been there, Bhagwan for FDI. I was sure the Bhagwan video, sir, FDI inspector. What I did for one. Because they only 4 seats, while for 10 seats. For 10 seats. The first is FCI case, and we were thinking that our seat will get retired or not. Only 4 seats. That 10 seats, that was also seats. Thank you, sir. Thank you. Excellent. Thanks. You people will be living today? Yes, sir. Yes, sir. Oh. Please have 8 o'clock is enough. 7:20. 7:20. I thought it later. I don't know.